Welcome, Dr. Arjun. Excellent. We're looking forward to an excellent talk from all our three titans. We are all very excited. You can see the audience is already there and super thrilled to be part of this exciting symposium.
I am as well, honored to be here. And to be in your presence, Meher. This is everyone, we are all here because of your guidance and leadership, dedication, and hard work. So congrats to you and hats off to you.
That's your kindness. Thank you so much. You've always supported us, and it's an honor to have you. And it's really amazing how approachable all our wonderful faculty are. This is indeed a good world. Testimony to the fact that the world is a good place is the fact that we have such huge people sitting across the globe talking to each other. Hello, Dr. Singh. Hello, Dr. NP Singh. How are you? I can see you driving.
Good evening. Good evening. How are you?
I'm good. You are a very busy person.
Right.
I hope you reach home on time, sir. So, just before we begin, I'd like to everyone that of course, I'll be saying it again, but our resource persons here are part of Dash to protect antibiotics. And Dr. NP Singh is one of our very strong, and you can see he's very pleased in his house now, I think.
So how are you? So I think we have entered at the right time.
Yes, sir, but I'd want you to be more comfortable. I don't want to be sitting in the car.
I think here I'm in, it's a petrol pump, so I have stopped my car here.
Okay, okay. As if you're comfortable
Actually,
there.
I was coming from UPSC Allahabad. There was an interview. So,
sure.
but
sure,
I think
sure.
I'm visible and audible.
Yes, 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 yes. Absolutely.
And that's fine.
Yeah.
That's fine.
Yes, Mubi, please type in your name as well as your that is important for us, and your email. So your name, email, as well as so that you can get the certificates.
So who's operating the slides?
Hello, sir. How are you? Good to have you with us, Dr. Raman Sardana.
Namaste, namaste.
Namaste, sir. I was just telling one of our colleagues that this is really an exercise in mentorship. We have so many superior beings with us, and we're going to be learning so much.
Yeah, I feel so.
Faculty. Hello, Dr. Reba. So I'll be operating the slides. We're just waiting.
Hi, Meher.
How are you? It's wonderful having you with us.
I'm fine, fine. Very good evening.
Good evening, ma'am. Ma'am, will you open your switch on your camera so we can have a look at you?
Yeah, sure.
Hello, ma'am.
Hi. Where am I? Oh, yeah.
Namaste, ma'am.
Namaskar.
So I can see Dr. Fahad Al-Zarjali has also joined.
Pranam, Dr. NP Singh.
Namaskar, sir. Namaskar. कैसे हो आप?
Hari Kripa, sir. All God's grace.
Yeah, thank you so much.
Dr. Raman is a force behind this symposium as well. I'm very grateful to him for allowing us to co-organize it with HISI. Dr. Fahad Al-Zarjali, good afternoon, good evening rather. Good to have you with us.
Good evening, Dr. Meher. It's nice to have you all and everybody around.
Absolutely. It's really a pleasure seeing so many eminent people with us. And of course, the esteemed audience. Zaima, I can see you. Good morning, good evening. I'm getting confused now with the mornings and evenings.
Good evening. Hi, Dr. Meher. Hi, everyone.
Namaste, Dr. Parijat, and namaste to everyone.
Namaste.
Hi, Raman. How are you?
Namaste.
Hi to everybody. Good evening.
Good
Good
evening.
evening.
Good
Good
evening.
evening. Good evening.
Hi there.
Hello, hello, sir.
Hello.
How are you?
I'm fine, thanks. Yourself?
Good afternoon. You're looking absolutely wonderful.
I'm not sure about that, but I'm surviving.
Looks like the weather is good over there these days.
It is, yeah, it's a beautiful afternoon.
Joy, I can imagine. Yes, you must enjoy these good days.
Dr. Meher, can I just check my audio? Rahila.
Good afternoon, Dr. Rahila. Lovely having you with us. We can hear you well and we can see you well as well.
Good, lovely, thank you.
Thank you for joining on time.
Dr. Meher, am I audible?
Yes, you are. Yes, you are, sir.
Okay.
Hello, Meher.
Hello. Hello.
How's everyone?
Oh, hello,
Happy to
ma'am.
be
Happy
attending.
Absolutely, ma'am. It's our honor, and we are thrilled to have you with us, ma'am.
Thank you. Thank you, Meher. I shall mute myself now.
Pranam, ma'am.
Hello, Raman. How are you?
All God's grace, ma'am. Ashirwad, your
God bless you
blessings.
all. God bless you all.
I can see Dr. Muna Al-Sadoun is with us as well, Dean, College of Medicine. Good evening, Dr. Muna. How are you?
Hi, good evening. How are you, Dr. Nihar, and all of our guests and participants? Thank you very much for joining us, and welcome all of you in this platform from SKU.
Thank you, Dr. Mona. It's such an honor to have you with us. And you really lead from the helm, and we are very happy that you're our chief guest. We'll be starting, I think, in another 3 minutes. We will be beginning the symposium, and really we are honored to have such a wide galaxy of eminent people joining us for this symposium. And thank you, Dr. Mona, for finding time for us.
Thank you very much for making me part of it, Dr. Meher.
You are an intrinsic part of it. You've always been there supporting us. So without you, it wouldn't have been possible. So thank you. Dr. Ken, we'd like to hear you too. Dr. Ken is an intrinsic part of this study, and all the audio and visual, everything apart from, of course, the technical aspects he manages. So Dr. Ken, we'd like to hear you as well.
Yes, I'm here. I'm just working on some of the technical stuff, but yes, I'm here and all systems working fine.
Thank you. Thank you so much. Dr. Maria, I can see you. Good morning.
Good evening, Dr. Meher. So good to be here.
Absolutely. We're thrilled to have you with us.
Yeah.
So during the course of this symposium, we will be introducing our very dynamic principal investigators of this study, Dash to Protect Antibiotics. And I'm very honored that they're going to be here with us. I can see a Dr. Lakshmi Narayan here, and I'm wondering if that is the Dr. Lakshmi Narayan. Dr. Zakaria, do we have you with us here today at this time?
Yes, Dr. Mihar. Good afternoon to everyone and good evening to those which are already evening time. And hopefully, inshallah, it will be a wonderful, informative day to all.
Thank you, Dr.
Good
Zakaria.
evening. Good evening.
So we've built a kind of a family here with 4 different bodies working together for the success of this symposium. So Dr. Zakaria is the head of department Microbiology and Immunology here in Sultan Qaboos University, and Dr. Raman Sardana is at this point he's representing Hospital Infection Society India, where he is a secretary. So we're very honored to have everyone with us. Shall we begin? It is time. Ken, do you think we should begin?
Yes, yes, that sounds good to
Yes,
me.
yes, please. On dot.
Absolutely. Hello, everyone. On behalf of Sultan Qaboos University, American Society for Microbiology, Hospital Infection Society India, and Dash to Protect Antibiotics, I welcome you to this very important and interesting international symposium on antimicrobial stewardship and patient safety. We live in very interesting times. We can connect with the best of minds and the best of audiences across the world while sitting in the comfort of our homes and offices, or offices, depending on what time of the day it is. There is much to commend a virtual symposium. We are indeed promoting a green environment and controlling or limiting our carbon footprints in this way. However, the thrill of meeting everyone in person is something altogether different. The thrill of having you here would have made our day complete. The thrill of you experiencing Oman in its entirety would have been something which I'm sure would have been absolutely indispensable. But in the interest of time and the interest of saving petrol, I think a virtual conference has much to commend itself. So just to make up for your absence, now this is something which happens to me very often, that the slides don't move. Luckily, they did move. So a very good evening to our illustrious faculty and august audience from Asia, in particularly the Indian subcontinent and the Middle East. It'll be a kind of late night for our East Asian audience and Australia. A very good afternoon to our eminent and illustrious faculty from Europe and esteemed audience from Europe and Africa. And a very good morning to our illustrious faculty from North America and audience from both North America and South America. I would like to begin by welcoming all the teachers, mentors, guides, as well as students to this very interesting symposium. Healthcare practitioners across the spectrum, promoters of animal, plant, and environmental health, valuable partners of DASH to protect antibiotics, dignitaries from Ministry of Health, Oman, esteemed SHE and ASM ambassadors, eminent HISI office bearers and members, valuable media persons, influencers, and activists, and invaluable citizens across all walks of life. I would now request you to please join me in welcoming our constellation of illustrious guests who are gracing our virtual stage. Chief guest, Dr. Muna Al-Sadoun. Our guest of honor, Professor Dr. David Livermore. Our three titans, Dr. Sanjeev Singh, Dr. Pawan Kapoor, Dr. Arjun Srinivasan. Our galaxy of eminent moderators, Dr. Raman Sardana, Dr. Reba Kanungo, Dr. Rahila Ahmed, Ms. Heather Burke, Mr. Keith Singh John, Dr. Fahad Al-Zarjali, and Dr. Anuj Sharma. These people wear many hats. All our esteemed guests wear many hats, and they have a habit of excelling in all of them. One common hat which they all wear is that they are connected with this interesting study, which has been christened DASH to protect antibiotics. Dr. David Livermore has honored us by being his patron, and all these eminent people on the panel on the right are experts, and they're guiding us through this study. We have 62 centers, actually going up to 64, but 62 at this point. And the spread is, as you can see over here. All our principal investigators are a dynamic lot dedicated to walking the talk of antimicrobial and diagnostic stewardship and trying our best to improve patient care and, of course, reduce antimicrobial resistance. Majority of our centers are in the Indian subcontinent and the Middle East. And over the summer, I'm very happy to tell you that we started partnering with Ministry of Health, Oman. And many thanks to Dr. Saif Al-Abri, Dr. Reena Al-Jardani, and Dr. Amal Al-Mani for their proactive approach and constant support. At this point, I would just like you to pause and enjoy the serenity of this picture. And what can be more a bliss than this? However, what one should understand is that at this time we are living in the best of times. Technological progress has been exponential. Healthcare advances have been phenomenal, and economic prosperity for as far as at least pre-COVID was spectacular. We're indeed living in the best of times. And in fact, one could call it the golden age. The problem with golden ages is they have a habit of declining and fading. And it is feared that we may be called a civilization which would have reached its zenith, but failed. One of those reasons could be the perils of climate change, which we are seeing. The other is the formidable foe which is breathing down our neck, invisible to most, but it is there, and that is antimicrobial resistance. And this has the ability to shake the firmaments of our very existence. I'd just like to walk you through this graph, and first of this annotation which has come. I took this from this is a life expectation in Britain and Wales from 1850 to 2003. So a person lived up to the age of 40, it was considered a ripe old age of 40, 43. It went up because the standard of living improved with the decline when the spine see that the standard of living was improving and the life expectancy increased. What we can also see here is that the life expectancy continued to grow. Life expectancy was because of miracle drugs, the antibiotics, and that's why this time is called the pre-antibiotic era, and this is the antibiotic era. The bugs, however, did not take the beating lightly, and they have responded spectacularly. And unfortunately, we're staring at a post-antibiotic era. And I'm taking the liberty of kind of showing you what could happen to the life expectancy if things are not taken under control. Things were slightly, I mean, this has really brought my heart to my mouth when I saw this picture in India, where life expectancy was between 20 and 30 for the longest of times. And of course, you can see the swine flu and the Great Famine. And then you see this spectacular exponential increase. And that is attributed to, of course, improvement in standard of living, but largely due to the antibiotics. We've used antibiotics, we've benefited by it. The problem is that this spectacular exponential rise could also spectacularly decline because of the extent of resistance that we have in our country and the kind of healthcare we have in the LMICs. So it's time to wake up and act now. Not only that, there are going to be some large-scale consequences where there could be compromise in food security, and with productivity declining, we could be pushed into more poverty, more morbidity, and more mortality. I'm sorry I took you through that melancholy route, but it's still a beautiful world. There's still time to act. Maybe nature is telling us to be frugal. Maybe it's telling us to be a minimalist. Maybe it's telling us to be frugal in our consumption of food and consumption of antibiotics. Maybe it's telling us to also be frugal in our consumption of its rich resources. Maybe that'll prevent emerging and re-emerging infections from coming in. So at this point, what we need to understand, it has to be a win-win situation. We cannot beat them. They've been here before us. I'm talking about the bugs. We cannot beat them at their act. They are far too good. So we need to learn to coexist with them. So maybe nursing a cold and sitting at home, nursing a diarrhea and sitting at home and not asking for a quick heal, or maybe even nursing a UTI and sitting at home, maybe better and better immunity takes control, maybe one of the solutions, although hoping we get better solutions than that. Coming back to the study, we have this very interesting questionnaire which engages our clinical colleagues. It promotes reflective, not reflexive prescribing. We will be together relearning some good practices and unlearning some inappropriate practices through this. The website we've built has all these questionnaires. They can be taken out easily, shared easily. And we also welcome people not part of this study to also peruse it and go through these questionnaires. The answers are also given. You just have to dig slightly deeper in it. So what we're doing subsequently is that we're going for an educational movement where we are promoting cephalosporin and fluoroquinolone sparing protocols. And the drugs we like to promote are these. We will be testing fosfomycin and pyrimethamine if they're not already being tested. And if we get excellent results, we would like to make recommendations that these drugs are available in the country so that we can continue fluoroquinolone and cephalosporin sparing protocols. The beauty is that there is little collateral damage, no clonal spread, and of course, they have a high concentration in urine, thus making sure that the patient heals, recovers. We will be saying no to cumulative antibiograms and saying yes to focused antibiograms, and we will be promoting mixing of antimicrobials, and thus building a heterogeneous antimicrobial policy so that we don't give the drugs to the bugs on a platter. Even in the second and third line, keeping our LMIC population in mind, we would prefer a combination of certain drugs rather than carbapenems as a resort for many of our people, where it could lead to decline in their monthly expenditure or monthly budget. So this particular website has all the resources so that everybody is able to extract things and use them at will, and there is no hindrance. Antibiograms have been raised already, have been prepared. It is not as easy as it looks, and Dr. David Livermore has been there with us in helping us prepare appropriate ones. The idea is to prepare an appropriate one so that we don't skew resistance, which is anyway peaking. We're creating some very good content for everybody. This is available in the open domain. It started with Dr. David Livermore very generously giving us his inaugural lecture. And then on behest of Dr. Manu, we had PUNET workshops with Dr. Sheila and Dr. Sultan spearheading it. And then Dr. Ken took a workshop on Zotero. This particular symposium will also be online so that maximum people can benefit by the wisdom of our speakers. It would not have been possible without the help of all our eminent team members from Sultan Qaboos University, Dr. Ken Masters, Dr. Leila Al-Yazivi, Dr. Nihal Al-Viami, of course, a microbiologist, Dr. Zakaria, Dr. Zaima, our ID physician, Dr. Ibrahim Al-Busaidi, Dr. Turkia, Dr. Badri. I've kept out the others for the interest of time, but there are many more. And this brings me to the moment we've all been waiting for, to our chief guest, Dr. Muna Al-Sadoun, the Honorable Dean, College of Medicine and Health Sciences. She is a true leader. She leads from the front, and she allows us to innovate and explore new openings. I welcome Dr. Zaima Al-Jabri, Assistant HOD, Department of Microbiology, to please first introduce herself and then welcome our Honorable Dean. Dr. Zaima. Dr. Zaima, can you hear me?
Sorry, I was muted. Yes. Good afternoon, good evening, or good morning to all of you, ladies and gentlemen. I'm Dr. Zaima Al-Jabri. I'm Assistant HOD of Department of Microbiology and Immunology at Sultan Qaboos University. And I'm honored to be here. And actually, I feel very proud to be part of such an elite university, which is Sultan Qaboos. I obtained my MD also from SQU. And today, I also feel extremely overwhelmed to get this opportunity to introduce our chief guest in this occasion, honored Dr. Muna Sadoun. She is the Dean of College of Medicine and Health Sciences. She is also the chairperson for Sultan Qaboos University Hospital Board. She is she had obtained her BSc and MD from Sultan Qaboos University. She holds a diploma of child health from Glasgow and Remand Center, and obtained her master's and PhD degree in community pediatrics, Nottingham University. Dr. Muna Sadoun is also a member of the State Council and a member of many national committees, including Child Protection Committee, CEDAW Implementation Monitoring Committee, Social Committee in the State Council. She is also a president of the Arab Society to Prevent Child Abuse and Neglect. Honored Dr. Muna is also a member of the inter-institutional committees, including formulating the Omani child law in 2014. She had several scholarly achievements in child health. As a medical student, I have always remembered Dr. Muna as a distinguished doctor and instructor in child development and health. We are so honored to have her here today as a chief guest for this symposium. And I would like all of you to join me to welcome honored Dr. Muna.
Thank you very much, Dr. Zaima. And I'm really honored to be welcomed by one of the graduates of SQU, the College of Medicine and Health Sciences. I would like to welcome all of our respected colleagues who are joining us today in the annual symposium on antimicrobial stewardship and patient safety in SQU today. I would like to thank the Department of Microbiology and Immunology in the university for coming forward and coming up with this huge project and extremely excellent collaboration with the institutions of academic and health service providing institutions in the region. Organizing this online symposium will definitely have an impact in strengthening more this partnership and making the objectives and the mission of the group in this study achievable, hopefully soon, with a great impact on the practices and use of antibiotic. This is done definitely was not going to be possible without the collaboration with the American Society for Microbiology, Hospital Infection Society India, and DASH to protect antibiotics. All of us agree that this topic is of great importance to the world. And I'm sure that the input of the active group will make a difference in the practice and better use of antibiotics. And I hope the scenario of the drop in the lifespan will not happen. Thankful for all of the effort that many groups, and your group is one of them, are trying to save the antibiotics and come up with better practices so that we will be away from the antibiotic resistant microbes. I'd like also at this moment to record our appreciation to Prof. David Livermore, Dr. Sanjeev, Dr. Bowen, and Dr. Arjun for making it possible to be part of the event. A great thank to the group of experts, including our organizers, whether from inside the institution or outside, the eminent speakers and moderators, participants and guests from different specialties, countries who are joining us today with the same vision and mission, which is directed toward the better for the humanity. I hope the best for the event, success for the project principal investigators and co-investigators in this multi-centric, multidisciplinary study. And finally, a special thanks and appreciation to Dr. Mihar Rizvi for her great efforts. I think the innovative ideas that this team is coming up with to expand the partnership of this project by linking the interested to join via technology is really a great achievement that they are making. And thank you, Dr. Kim Master, for your contribution also. And thank you for having me. I hope that I didn't take a long time because I know that everybody around is just waiting to hear about antibiotics and what can have, be done so that we will have a better life. So thank you again, and go ahead, Dr. Mahar Rizvi, so that you will continue your event.
Thank you so much, Dr. Muna, for those wonderful, heartening words. I'm happy you said that the life expectancy will not plunge. That our words should be engraved in gold. And you've always been a source of strength to us, and we look forward to your support and your encouragement and your direction in future as well. Thank you, Dr. Muna. And now, ladies and gentlemen, we welcome our guest of honor. Dr. David Livermore is a doyen amongst microbiologists. We know that several generations of clinicians and microbiologists have grown up with his teachings and learnings. Dr. David Livermore has shaped our knowledge about bacteriology and antimicrobial resistance through his brilliant, ceaseless, cutting-edge research. Sir, you have a huge number of fans all over the world. You have one fan waiting for you right around the corner, and that is our very distinguished guest, Dr. N.P. Singh, who is head Department of Clinical Microbiology, University College of Medical Sciences. He himself is a crusader of antimicrobial stewardship in a big way. Dr. N.P. Singh, will you please introduce yourself and then do the honors of welcoming our esteemed and illustrious guest of honor?
Yeah, good evening from India. I'm Dr. N.P. Singh. I'm Director, Professor, and Head of the Department of Microbiology at UCMS and GTB Hospital. And I'm grateful at the outset, I'm grateful to the organizers of Virtual Annual Symposium 2022 on Antimicrobial Stewardship and Patient Safety for giving me this wonderful opportunity to introduce today's guest of honor, Professor David Livermore, a doyen of medical microbiology, a sunshine of all microbiologists and clinicians at the same time. And I'm following Sir since 80s, when since 80s, when our first paper was also published in Journal of Antimicrobial Chemotherapy, and I know that Sir has edited that journal. So Professor David Livermore has enriched the world with a staggering 500 profoundly thought-provoking publications which cover the entire gamut of bacterial resistance. He has pioneered research on antimicrobial resistance in a veritable plethora of microorganisms and has enriched the world with his meticulous, painstaking research. His work has influenced several generations of microbiologists and clinicians alike. Across 40 years, he has belonged and then led teams that have defined the evolving epidemiology and molecular nature of antimicrobial resistance. He regularly appears on Clarivate's most cited list, has edited for multiple journals like Journal of Antimicrobial Chemotherapy, International Journal of Antimicrobial Agents, Journal of Medical Microbiology, and has served on many UK government's advisory committees on antimicrobial resistance and healthcare infections. He consults widely for the medical industry on antibiotic development and rapid diagnostics. He is currently leading an important multi-pronged, multi-centric study called INHALE, which will have far-reaching consequences as it studies the utility of molecular diagnostic tools in leading to better patient outcomes, promoting antimicrobial stewardship and cost saving in hospital-associated pneumonia and ventilator-associated patients vis-a-vis the conventional lab practices. At this time, he has given an important guidance to all of us, and I will quote his guidance. That is, I quote, always look at raw data and ask, what is this telling me? And not how does it support conventional opinion? If the data show something unexpected, find a second way to test and hopefully confirm it. Once you are sure you are right, publish and stand by your findings, whatever conventional wisdom may upset. Alongside, Dr. David Livermore has walked entire perimeter of United Kingdom and Wales and half of the Scotland. Sir, I once again welcome you. In this conference on antimicrobial stewardship and patient safety. Thank you.
Okay, thank you for the kind introduction. It's presently telling me I can't share my screen. Perhaps I'm being impatient.
Yes, no, I have to stop sharing. Just a moment, sir.
Okay, I am being impatient.
This is where this machine is stopping me. It stopped, yes. Very welcome, sir. We are absolutely thrilled to have you with us as always and looking forward to your presentation.
And now you should be seeing my screen, yes?
Yes, sir.
Jolly good. Well, thank you indeed, Mayor. Thank you, Dr. Singh, both of you, for the very, very kind and generous introduction. I'm not sure grateful to you here. Ladies and gentlemen, as those quotes have just said, I would urge you in any study, in any piece of scientific work, to always look at the data, always keep asking yourself questions about it, always try to be rigorous. We've just now lived through, what, 2.5 really remarkable years of the pandemic, when, at least in my country, and I think in many of yours, we were promised initially that we would be led by the science. But I fear we were not led by the science. I fear that we were led very frequently by the propaganda. I don't seem to have heard, at least in the major scientific journals, nor in the major media, a debate on the cost benefit of lockdowns. Yes, they may have slowed circulation of the virus, but they cost an absolute fortune. The costs will have to be repaid over many years. That will impoverish people. It will harm public health. Where has the debate been about the value of vaccinating children who are of minimal risk from COVID and who, if they catch it, will be protected for longer than they would have been by the vaccine? About masks, where the WHO said that were of no value before the pandemic, where 2 trials done during the pandemic found no value, and where country after country has imposed mask mandates without any impact on rising trajectories of COVID. We desperately need good, hard, rigorous, objective science. And with that, let me turn to antibiotic resistance, where surely we have a problem. Here's the map of Europe. we're looking at carbapenem resistance in Klebsiella pneumoniae from bloodstream infections. Look at Italy there, 2% resistance in 2008 to 30% resistance actually by 2012, let alone 2015. And see the other countries turn the warmer colours as resistance rises. Slovakia, Romania, Greece. Real problems for many of these organisms are highly resistant to multiple antibiotics. But I would be very, very wary of extrapolating those sorts of observations for intensive care unit patients to statements like this, and we've heard a little echo of them this afternoon or evening. This was one from our chief medical officer in the UK, that drug resistance could take all healthcare back, take healthcare back to the 1800s to destroy those gains in life expectancy. Well, let me answer the question posed today, and let me comment on that headline. It's not going to. This isn't 1800. Bacteria, medical bacteria hadn't been identified in 1800, so we can't certainly say what was going on except for classical infectious diseases. But this is the 1940s, if you look at the left-hand panel, and these are bacteremias in hospitals. And what you see immediately is that 90% of the bacteremias were caused by gram-positive pathogens, and half of them by strep pyogenes. Strep pyogenes has remained entirely susceptible to penicillin and multiple other antibiotics. Staph aureus, that's the deep royal blue colour, another big slice. Yes, it has been adept at developing resistance, but when I last counted, we had 13 antibiotics in 9 different classes, which were near universally active against Staph aureus, including MRSA. We're not going back to 1800. We may be hitting problems with treatment of a few classical infectious diseases, tuberculosis, gonorrhea, and some of our advances in terms of intensive care medicine, where we see multiple resistant gram-negatives are at risk. But we're not going back to 1800. But we mustn't be blasé. We should do what we can, where we can, how we can, to reduce the rise in antibiotic resistance. And we have to be candid that there's a lot of bad antibiotic use which drives resistance for no really very useful medical purpose. This slide, and forgive the rather complicated axes on it, but the horizontal axis there is amount of beta-lactams used, and the vertical axis is a measure of the probability of resistance to beta-lactams in a pneumococcus, in Streptococcus pneumoniae, and the codes are different countries across Europe. So what you see is countries like the Netherlands, Denmark, Sweden, Finland, to a degree the UK, have relatively low usage, low rates of resistance. But if we go to the other end, Belgium and Portugal, Italy, high rates of usage, high rates of resistance. And the populations of Portugal, Belgium and Italy are not noticeably healthier as a result of that rather heavy usage. We can also look across individual hospitals, and this is the UK. Total antibiotic usage per 1,000 occupied bed days is an OBD. So it's a measure of amount of use per occupied bed. And if you chop off the bottom 10% there and the top 10% over there, those are mostly unusual specialist hospitals, psychiatric places at this end, and major transplant centres at the other. What you see over the 80% in the middle is about a 2-fold variation in antibiotic usage. Why on earth are the places at this end using twice as much antibiotics as those at this end? Do they have better outcomes? Do they have worse outcomes? Are they being wasteful or not? These are things we must answer. Where is the optimum on that graph for a normal district general hospital? As I say, forget the very top, the very bottom. And let's also be candid. There's a lot we don't know. I've shown this graph many times, this picture many times over the years, and nobody's yet managed to give a clear answer. These are 3 models of empiric prescribing control within a unit. The first one's restrictive. For a type of infection, say a complicated UTI, we standardly give antibiotic A. We give it to every single patient, and only once we've destroyed it do we switch to using antibiotic B. Is that the best thing to do? If you think about gonorrhea in the community, it's how we've destroyed successive antibiotics, one after the other. Sulfonamides, penicillins, tetracyclines, fluoroquinolones, to a degree cephalosporins. Is cycling better? 3 months where A is standard of care, 3 months where it's B, 3 months where it's C? Or do you just destroy all those antibiotics together? Or is it best to get a diverse, mixed usage of antibiotics? We desperately need good studies that resolve this. The people who've tried to do it have tried to do it in ICUs, which may well be the very hardest place of all to try. But let me now turn in my last few comments to community urinary tract infections, because needless to say, that's what serves concentrating on. It's what accounts for so much of community antibiotic usage. And we all, I hope, agree that somebody who's got a UTI does need an antibiotic for treatment. It's not like a community respiratory infection where lots of the people getting antibiotics had a viral infection and didn't need them at all. This is from a European survey recently published. And I put it up to make the point that our standard old antibiotics here, cephalosporins, coamoxicillin clavulanic acid, if you prefer, ciprofloxacin, trimethoprim, all have resistance rates of 20% or more. Increases the hazard of failure. And remember that these UTIs are the commonest source of E. coli bacteremias. If you've got a UTI, you're actually very unlikely to get an E. coli bacteremia. But nonetheless, more bacteremias come from E. coli UTIs than any other source. So we can stop those that are going to give to a more serious infection. We do the patients a big favour. The antibiotics with lower resistance rates, May has mentioned them already, fosfomycin, nitrofurantoin, mucilina. They've kept their activity better. Their limitation is that they are no good if the infection has started to ascend. So here we have a conundrum. The antibiotics which were good if the infection had started to ascend are compromised by resistance. The antibiotics that are keeping their activity well, that aren't compromised, are not so good if the infection started to ascend. Here's what's gone on in the UK, and I apologise for this left-hand panel because it's a plot that's a little hard to get your head around. Trimethoprim as a proportion of trimethoprim plus nitrofurantoin. So the dotted lines are individual UK regions. The orange line is the mean for the whole country. So it comes down. What that means is trimethoprim's going down. What it doesn't show you directly but has to follow is nitrofurantoin is going up, precisely because we got concerned about the prevalence of trimethoprim resistance and switched to a drug, nitrofurantoin, to which there is much less resistance, but we know is less good if the infection started to ascend. What's happened to E. coli bacteremias? Well, they kept going up all the while. I've truncated the graph at 2019 because in 2020, needless to say, we had a lockdown. Numbers went down, but I fear that's because patients didn't present to hospital and some died at home in consequence, or some who were about to get a bacteremia, at the end of their lives, got a COVID instead. But it again shows you the complexity here, that we switch into a drug that in terms of resistance is better, but which has its own limitations and which hasn't caused any immediate shift in what we want to change, those E. coli bacteremias. Ladies and gentlemen, I've talked quite enough, but hopefully I've made my message clear, which is always think, don't fall for hyperbole, recognize exaggeration. COVID has been a nasty pandemic, that's for sure, but it has not been one of the great plagues of history, and what we did may well have been disproportionate. And yes, we have serious antibiotic resistance problems. We have a few classic infectious diseases which are becoming hard to treat. We have a big problem in specialist hospital units, but we're not going back to the pre-antibiotic era. And turning to stewardship, and stewardship's actually critical to what Dash is trying to do. We know what bad stewardship looks like. It's profligate antibiotic use. We still don't quite know what optimal stewardship looks like. And so we must test different things. We must keep an open mind. We must try to find out what is that best compromise on antibiotic usage, which preserves antibiotics for the future, which is encouraging antibiotic development, but which simultaneously gives the best treatment we can for our patients, to whom our first duty lies. Thank you.
Thank you so much, sir, for that excellent guidance, for reassuring us, and for telling me for the hyperbole that I did, and I did it exactly for this, so that we come back to where we really stand. Are we going back to the 18th that you put there? I would have thought that, I mean, I'm talking about LMICs here, really, where the health standards may not be optimum. And could we say the standard of living will keep our life expectancy to 50, or we will continue at 60, 70?
The future is unknown and unknowable. All we can try to do is work as best as possible on present evidence. But hyperbole is also useful because it creates debate. It's dangerous when it's used in the way it was with COVID. Very dangerous.
True, true, true. Absolutely. So we went overboard there. We should not go overboard with our fears for the future. We should be very careful and what should we say, judicious in our usage. And of course, as a whole world, not just healthcare practitioners, but the whole world needs to be on board on utilizing these very important resources. Sir, it was an amazingly wonderful presentation. Again, pearls of wisdom from you, which we will keep and preserve till next year when we meet you again and learn some more pearls and keep them to our heart. Thank you so much, sir.
My pleasure. I shall enjoy listening to the rest of the symposium.
Our honor, sir. Our honor.
Okay.
So, ladies and gentlemen, that was Dr. David Livermore giving his much-awaited address. Again, immense pearls of wisdom, a lot of food for thought, but great reassurance that we're not going anywhere soon. We're still going to be around despite the bugs being smarter. I mean, that's what I personally feel. They were here before us. They're going to be there after. But yes, our ingenuity and our wisdom will keep us in place. Thank you so much, sir. And again, my slide says, so we come next, ladies and gentlemen, we are now ready for our first distinguished speaker of the day, a veritable titan, Dr. Sanjeev Singh, who will be discussing strategic implementation of Antimicrobial Stewardship Program. I'm welcoming our eminent moderators, Dr. Raman Sardana, Dr. Fahad Al-Zarjali, and Dr. Heather Burke, who will take the talk further. Before we do that, I would request Dr. Yamuna Devi, our principal investigator from Chennai to please introduce herself first and then welcome our eminent moderator. Dr. Yamuna, please.
Yeah. Hi, Dr. Mahir. Thank you so much. I would like to thank the organizers for giving me this opportunity to introduce Dr. Raman Sardana. I am Dr. Yamuna. I am a consultant infection control. I'm also taking care of the CSST in Main Apollo Hospital, Chennai, India.
Wow.
I come from this very beautiful country with full of culture and heritage. I'm also a previous SHE ambassador for the year 2021. It gives me immense pleasure to introduce Dr. Raman Sardana because we come from the same institute, Apollo Hospital. And Sir has been a pioneer and the backbone in establishing the clinical laboratory in Apollo Hospital in Indraprastha, New Delhi. He had also co-authored National Treatment Guidelines of Infectious Disease version 1 for the Government of India in the year 2016. He has also co-authored the National Guideline on Upgrading of Labor Room Intensive Care Unit for the Ministry of Health and Family Welfare for the Government of India in the year 2016. He is also awarded the Prashasti Patra by Government Delhi for the Pulse Polio program held in the year 1995. Sir has shared and chaired many members, many societies nationally and internationally. He is the advisory committee and core expert group for the antimicrobial resistance program for the Government of India in the National Action Plan 2022. He is also a member expert for the COVID-19 public-private partnership group under Ministry of Health and Family Welfare. He is also one of the members in Microbiology, Hospital Infection Control and Biomedical Waste Bureau Indian Standard. He is also a council member representing India for the Asia Pacific Society for Infection Control. He is a member in dialysis, blood-borne virus, member expert in injection safety and infection control, WHO a member for also Government of India in the expert group on patient safety network. He has conceptualized and instrumentalized the Guinness World Record on hand sanitizing relay in the year 2016 at Indraprastha Apollo Hospital. He has been conferred the Scroll of Honor from Delhi Medical Association and other non-government agencies for contribution in community health projects as a COVID warrior for the year 2020. Sir, I would like you to introduce on this platform and take us forward for the next proceeding.
Thank you, Dr. Yamuna, for an it's a pleasure to have been introduced by a colleague from Apollo, and I look forward to our eminent speakers. Dr. Mayor, one thing I just wanted to know, the other moderators are going to be introduced right now, or
just the moderators quickly. That was slightly, we'll ask our resource persons to shorten the introduction slightly. Sorry about that, but sir, you're an institution in yourself, and thank you, Dr. Yamuna, for welcoming Dr. Raman. I will now welcome Dr. Heather Burke, Regional Director, MENA, CDC, and for welcoming her, we have Dr. Omnia Tahir, our Principal Investigator from Cairo, Egypt. Dr. Omnia, please.
I really would like to thank Dr. Mahir for giving me this opportunity to be in this great symposium. I'm Dr. Omnia Nabawi from Faculty of Medicine, Ain Shams University. I'm Associate Professor of Clinical Microbiology and Infectious Diseases. I'm really honored to, it is a privilege for me to introduce our eminent moderator, Dr. Heather Burke. She is the Regional Director, Middle East, North Africa, MENA Regional Office, U.S. Center for Disease Control and Prevention, Muscat, Oman. Prior to this, Dr. Burke served in Amman, Jordan, as the Regional Program Director for the CDC's Division of Global Migration and Quarantine, second to the International Organization or Migration. She has worked on global health issues entirely of her career and in a variety of settings, with much of her work tied to the Middle East. With the CDC, she has worked on issues related to migrant health, infectious disease surveillance, outbreak response, malaria treatment and control, a global immunization, and served as a state assignee to the Minnesota Department of Health Refugee Program. She was also based in Kenya for 5 years, where she helped set up the CDC Global Disease Detection Platform. She earned her Master of Public Health degree from the Johns Hopkins University School of Public Health and her Master of Arts degree from Johns Hopkins School of Advanced International Studies. Welcome, Dr. Heather. We are pleased to have you today.
And the final moderator of this talk, Dr. Fahad Al-Zarjali. I welcome Dr. Arina, Principal Investigator from Lucknow. So please do the honors.
Yeah, very good evening to all the dignitaries, moderators, speakers, and the participants. It is my honor and privilege to get opportunity on this forum to introduce myself. And this is Dr. Arina Siddiqui from Lucknow, India. I'm a clinical microbiologist and head infection control department at Sahara Hospital, Lucknow. I'm an enthusiastic antimicrobial steward. With immense pride and great pleasure, I take this opportunity to introduce Dr. Fahad Al-Zarjali. It is my real honor to throw some light on his eminent career. His valuable insights and profound knowledge that he will impart in this session will definitely add to our current knowledge. Dr. Fahad is a national member of Science Commission at UNESCO. He is a focal point collaborator with Sultan, Qaboos University and other European and American universities. He has expertise in molecular biology in designing assays and tests to detect pathogens and resistance genes. He has an abiding interest in AMR. His research focus is understanding human disease pathogenesis with special emphasis on hormonal dysregulation and alteration in JAK-TSC-STAT pathway. Specific investigation is conducted on non-alcoholic steatohepatitis and inflammatory bowel disease, thymic rejuvenation, renal cyst development in tuberous sclerosis. He has expertise in complex heritability studies on metabolic syndrome and study on lipid and blood glucose variability in extended families using measured genotype analysis. Through interdepartmental activities, he is responsible for analysis of monogenic disorders using next-generation sequencing with focus on familial hypercholesterolemia and hypertriglyceridemia. With today's session, I'm sure there shall be innumerable takeaways that we can implement at our institutions and bring a definite change. So I welcome Dr. Fahad. Thank you.
Thank you so much. Ladies and gentlemen, now we're all ready to listen to the great talk by Dr. Sanjeev. He is an inspiration to millions. He has formidable expertise in practically every conceivable aspect of healthcare. I welcome our honored Dr. Raman Sardana, Secretary, Hospital Infection Society of India, to please do the honors. Dr. Raman, please.
Thank you, Dr. Meher. It is indeed a great honor to introduce a personality like Dr. Sanjeev Singh, who's been a great friend, in fact. And you know, sometimes one tends to feel so funny in front of his whatever he has achieved, especially while working at the helm of affairs in Kochi. So Dr. Sanjeev is a well-known figure in India and abroad. So I won't go in much details. So after doing his post-graduation in pediatrics and masters in hospital management and a PhD in infectious diseases, he worked as a regional coordinator with WHO. And then subsequently, how we know him more is his role as Chief of Medical Services at Amrita Kochi, which is a 1350-bedded university teaching hospital. He is now currently he is the medical director of Amrita Hospital, Faridabad, and designated as resident medical director. So he has got many fellowships, and as you can see, and this will not suffice, you know, to introduce him as a personality, because he's way above whatever we can write on the screen. So he's got major publications, more than 100 international and national publications, with an H index of 15 and has got 14 international and national funded research projects, all-rounder, in fact, very wise person, and always somebody to look forward to meet and listen to his wisdom. So won't take much time. Dr. Sanjeev is going to talk on one of the toughest challenges we face in AMR and AMSP programs. So that is the implementation. So over to Dr. Sanjeev, please.
Thank you so much, sir. Ladies and gentlemen, please put your hands together for the dynamic Dr. Sanjeev Singh. Sir, we are thrilled to host you, and the screen is yours.
Thank you so much, Dr. Raman. The work which you do at Hospital Infection Society and in your institute is something which is phenomenal. Thank you, Dr. Meher, for organizing this. It's one of the toughest things to get all the team together across the globe, and what you have done is something which is outstanding. Getting everybody together for antibiotic stewardship, and one of the most difficult topics, UTI, because we still don't know what works, what doesn't work. And it's good to have the collaboration between Sultan, Qaboos, HISI, and American Society of Microbiology. So great work, Dr. Meher, great work by you and your team. And we would like to really sort of engage with all of the stakeholders and see whether we can create any kind of a difference. So I'm going to talk about strategies, and I don't know what strategy works in which country. It's always been a trial and error. And as Dr. Livermore mentioned, pandemic was a great piece where we learned quite a bit. And then we realized that there are various pandemics which keeps coming, and they keep teaching us various lessons, and good infection control practices was one. And definitely we also realized that there were many antibiotic stewardship programs which worked, which didn't work. And that is where I think pandemics and the history of this is a great learning. What next is definitely, we don't know, but the anticipation is AMR, and that is why we are all here together. There is a crisis. There is a phenomenal report which comes from Jim O'Neill, where he has written that initial research looking only at the part of AMR shows that the continued rise in the resistance by 2050 would lead to 10 million people dying. And it's not a joke. It's going to be something, a great disaster. And every year, a reduction of 2 to 3.5% in GDP. So it's going to basically harm every nation in totality. AMR is a difficult ball game. We all realize that it is there, each sector, but it is like an Indian traffic where it is however, wherever, and whenever. There has been a loss of political will, but there is a lot of work which has already been done. Governance in each institution requires a lot of pulling up. No standardized surveillance system, though there is some kind of a network which is getting developed. The clinical engagements needs a lot of improvement. So there are multiple, and everybody knows about it. So One Health is a big topic. So we are unable to get hold of the human health, and so it is again a big ball game. And then there is no structured education and training, and that is where I think as a human health we could be a good contributor to make it happen. So resistance levels are definitely high, and you're all have been working, and the antibiotic consumptions are increasing. So, and would not spend time. Consequences are very well known, because if we don't contain this, the cost is going to be high, the morbidities, mortalities, and length of stays are going to be high. What has India done so far? Phenomenal work, though it may be just a drop in the ocean, but there has been an national containment plan. There has been a lot of states' participation. What has states done so far? Some of the states have taken lead. Kerala, MP, and Delhi have got the team together. and have put in some kind of a strategic action plan for AMR containment. I can talk about Kerala because I have been very closely associated. So AMR, once you deal with it, you realize that it is a very, very big game. And whatever you do feels so small. The bandwidth which you need to travel is just immense. So there are 35 medical colleges. You need to get hold of all of them because you need to teach them or catch them young with undergraduate, postgraduates, and the prescribing pattern. If you start working with a medical college, you soon realizes that everybody needs to sort of improve. And this is where we reached out to the government of Kerala when within our ICUs, we realized that nothing is moving because they already been pumped in with antibiotics. So everybody needs to improve for a comprehensive improvement. We also realized that there are these, other than the district hospitals, there are these taluk hospitals which also needs to play its own role. 99% of literacy, health-seeking behavior, primary health setup, fantastically done well since 1842, still has a lot of problems. 48 community health centers, and then close to 7,000 private hospitals and 50,000 plus physicians. So this is the bandwidth which we need to travel. And this is where we need to strategize ourselves to be able to put everything together. And it's going to be tough because it is just not about teaching. It is also about behavioral change and thinking about the future, which Dr. Meher, Dr. Livermore did speak about. So public-private partnership is the only way forward because there is where we need to engage with all the stakeholders, all the societies. This is what we did in Kerala with the phenomenal support from WHO India. And we also reached out to 18 professional societies from associations of physicians, surgeons, ENT, orthopedics, dental. And then we formulated a clinical plan, a clinical guidelines, which got released. Then we formulated a AMR container. And we thought that something has been done. And nothing basically happened on the grounds. And post that, there was a 2-letter word which is extremely important in the state government, is the government order, GO. And that got released for everybody's participation, for all hospitals, for all labs and all pharmacists. And there was a decent monitoring mechanism which also got established. So what are these strategies where people need to sort of get together for a good antibiotic prescription practices? One is definitely having a plan, a national level plan, national action plan, which should merge with a global action plan, which is merging with the national action plan, which merges with the state action plan. And then it definitely needs to percolate down. The other strategy, which is good, is about starting smart and then focus. And this is what I feel is a good strategy because pre-authorization many at times in an institution becomes difficult because there is a right to prescription by each physician which gets questioned and they feel threatened. And it is good to just start smart when you have a good antibiogram by site specific, you have a good antibiotic policy, both in outpatients and in inpatient setting. And then based on that, you promote a good prescription practices at ER, at OP, and at IP. So looking at right drug, right indication, right dose, right time, right duration for every patient, and then maybe looking back and de-escalate, stopping IV oral switches and things like that. There is again a good strategy which Institute of Healthcare Improvement suggested, that formulating a driver diagram, looking at each problem, and then formulating something which is called as primary drivers. So if there is an antibiotics utilization, what could be a primary driver? So that is a timely initiation of antibiotic, de-escalation, data monitoring, and then what could lead to the secondary drivers, and work on these change agents. So every person who sort of becomes a department or a process champion or a process owner, and work as work for this change idea, which gets implemented and monitored from time to time basis. There is also a mechanism where we could formulate a good antibiotic policy plan based on either a community-acquired infections or a hospital-acquired infections or a nosocomial infections, which gives a guidance note for clinicians to basically start a good empirical therapy based on the antibiograms, and then work on a more targeted therapy. And moment the samples, the report comes in, gets into a de-escalation or an escalation mode. There is a very easy mechanism also, which if we don't have the resources for a continuous monitoring, we could look at point prevalence surveillance. And point prevalence surveillance is for AMR has been very robust. Dr. Dilip Nathani and the whole group basically promoted this concept, and it comes out very handy, where you on one point of day you look at from 8 a.m. to 8 p.m. the prescriptions which has been there in each inpatient setting and ICU setting, and that gives you a phenomenal insight to what has been prescribed, and then take an action based on that. There are other antibiotic stewardship team, which is a multidisciplinary team, which needs to be created to get a good comprehensive strategy, where everybody from the clinical team, from the governance team, from infection prevention control team, from the lab medicine team, the drugs and therapeutics, and all the support services with infection prevention also sort of participates, and then they create some an environment for a rational prescriptions and look at all unwarranted prescriptions at all points of time. There is also Dilip et al. Did present about core strategies and supplemental strategies. So this is what got adopted at the surveillance program at ICMR, where there is a formulary restrictions, pre-authorization, prospective audit, and a multidisciplinary team. At times it gets difficult with the formulary restrictions and pre-authorization, but then supplemental strategies are extremely critical, which needs to be adopted, which could be de-escalation, optimization, and antibiotic order form, looking at the justification, CDSS, and the surveillance system. And Dr. Livermore did talk about some of these cycling and combination therapy. So front-end strategy and a back-end strategy is something which works, which we have adopted, and many of the hospitals within the country, I find it extremely handy. So there is an antibiotic prescription pattern as a good strategy, and then there is a restriction based on select antibiotic dosing, which could be adopted within the institution. So it could be easy as a WHO classification of where being followed, and look at all the restricted antibiotics, be it colistin, tigecycline, doripenem, and things like that. And then look at and do a prospective audit, which could be an electronic or a medical records audit, and day 1, day 4, day 7 review, and stop whenever it is required, or escalate or de-escalate. We did that, a similar exercise, and then we realized that loading dose is a problem. There are 8-9 antibiotics which require to have loading dose whenever it is prescribed. Dosing is a problem, and duration of antibiotics is a problem. So every time you prescribe this, you need to sort of again go back and talk to the team, engage with them, invest the time, so that the appropriateness of the practices are followed. There is definitely antibiotic prophylaxis is an issue, and there was a surgeon which basically always thought that giving more antibiotics helps, and he was prescribing meropenem and micapenem linezolid as a prophylaxis. And we matched the similar between 2 units of the surgical site infections, and there was another team which only prescribed, which was rational cefuroxime. And then the surgical site infections came down with the rational practices. So this particular idea of using more antibiotic, using more power to control infections is also irrational. Plus, there is a cost to the patient, and the cost of care in India is a big determinant. So can each institution play a role towards good antibiotic practices following strategies, which we just mentioned? And answer is yes. And I could give my hospital's example. There's a multidisciplinary team which has ID fellows, which has clinical pharmacists, microbiologists, hospitalists, and they all sort of come together and take a call. There is a Donabinian model by the multidisciplinary team, which is followed, where structure, process, and outcomes are always defined. So there is everything in blue is a structure, then there is a process in green, and then look at always review the outcomes which you have sort of formulated each quarter, and always look at what are the gains for the policies which you have adopted. So appropriateness of rational prescriptions did improve. There is also vis-a-vis a decent healthcare associated infection status, which did improve. The mortality rate of infections did drop down, but then it did increase later. And there was multiple reasons, but then there is a cause of concern where we need to look back and improve. There is length of stays, and because of that, there is an opportunity to admit more and to do more cases, and so there is a significant improvement in length of stays just because of antibiotic stewardship, where rest of the parameters stays simple. There's a daily defined dose improvement with all the restricted antibiotics which did take place, but it did not also lead to a pressure effect on other antibiotics. So rationality did make a lot of sense. There is an impact which happens because of these restrictions, and there is a drop down of restricted antibiotic use. There is a cost benefit which is also important, though many a times it is said that antibiotic prescriptions does help the kitty in the hospital. But we looked at the direct cost, we looked at the indirect cost, we looked at the opportunity cost, and every year on year, there was a cost benefit, maybe a loss to the hospital because those antibiotics did not got sold, but the cost benefit was close to 2 crore, which is decent. And this is the benefit which goes to the society, where the patients did pay less. Vis-a-vis looking at infection, all healthcare associated infections. So the process of hand hygiene, isolation, wound management, looking at all the outcomes like readmissions and the length of stays and mortality, and all device related infections. So when you do both the programs together, AMR containment as well as healthcare associated infections, there is a significant drop which happens. So what we realize is your investment in just training and back to basics training of $1, the return of investment is close to $236, which is remarkable, and which is where we need to come together as a team, and the management did need to support. This is a work which we did with Imperial College, and using a tool which is called a sociogram, looking at ethnography. We shadowed the clinicians on round, and we looked at their communication pattern. And we realized that though we are a not-for-profit university teaching hospital, we did realize that the communication to the patient is limited, and most of the communication do happen with the carer. So this concept about being a patient-centric hospital is not true, at least in India. It is more of a carer-centric and a patient-centric hospital, because carer reveals and most of the information and takes care of most of the information of the patient. But the rounds are hierarchical in nature, and the communication of the senior surgeons, senior physicians on infection control and antibiotic stewardship is minimal. With our work, other than quantitative and qualitative, the rate of de-escalation was also taken care. We also looked at some of the PKPDs and of most of the restricted antibiotic. Inappropriate loading dose for colistin was a huge problem, including the participation from the nephrology team, which on a repeated engagement did improve. There is also a pattern of diagnostic stewardship, which would help in antibiotic stewardship. Sending the right kind of samples for all device related is again important, and that is again a behavioral change which from the clinical team as well as from the nursing team, which needs to be stressed upon. Mandating the right kind of samples every time is critical. Again, a therapeutic drug monitoring mechanism, a practice which is very difficult and rare. There is a sensitization which needs to happen, especially with some of these antibiotics like vancomycin, colestins, tigecyclines, where we need to optimize the drug dosing, and which would also result in the prompt reduction in the withdrawal of the therapy. Loading dose many a times was not being practiced, so we empowered the nurse despite the fact that the clinical team doesn't write down on the drug chart or on electronic medical records. They need to every time for the select 9 antibiotics give a loading dose, because that's the rational practice which needs to be adopted. So a lot of empowerment is important from the support staff, which needs to be also given. There are various guidelines where the clinical pharmacist developed and that got shared. There are we soon realized that we were working on antibiotic stewardship. We immediately shifted to anti-tubercular stewardship. We shifted to antifungal stewardship, because unfortunately, AMR program is so big along with hospital infection control that you realize that there are so many parameters which you need to sort of take care. We started a candidemia care bundle with looking at appropriate selection of antifungals, removal of lines at appropriate time, giving an opthal consult, and looking at their administration at as per the guidelines. And we implemented this for a Candida auris infection rates. We also realized that there is a huge kick which happens when a newer antibiotic gets introduced. And it is important also to immediately restrict that, because you never realize that it gets prescribed despite being a tertiary and a very specialized organ transplantation congenital heart surgery center. So it is appropriateness of these doses and appropriateness of beta-lactam inhibitors, anti-tubercular stewardship, antifungal stewardship is, again, this is where a comprehensive stewardship program would help. And then changing the behavior by every time when you prescribe an antibiotic, writing an indication, because unfortunately we send this whole idea of writing query before each diagnosis. It makes it life very simple, and then based on that you keep sending samples, and based on that you also recommend some of the antibiotics. So changing this behavior of writing an indication every time you prescribe an antibiotic is again an important step. So what we have done right now is created more champions, and this is a huge contribution where 122 general practitioners have been trained for 14 districts in the state of Kerala, and they have been taking sessions for the rest of the general practitioners at various centers, and they take sessions on 5 modules. But these champions have huge interest, huge passion. They are knowledge. They have robust knowledge, and they work with the content. So sum up, our antibiotic stewardship program needs to be comprehensive, where public and private, all institutions needs to participate. Infection control is an important program which needs to merge with this stewardship program, and that's a big strategy. We keep talking about training, but it will not have that kind of impact until unless the behavioral change and that quantitative and qualitative nature of work needs to sort of come together. We need to create collaborative, and this is what Dr. Meher and the whole team has done along with HISI and ASM is phenomenal. And this collaboratives like this is going to have a lot of impact. Stakeholders like all of us needs to be engaged. There are lots of, what we generally do is keep following, and we become a good follower. But what is important is also look at something which is out of the box and be patient and perseverance on our approach. We put in a lot of structure, and that is what we are good at, but looking at also at process and outcome would be important. And definitely standardization of work. And I would really like to thank Dr. Meher that somewhere down the line, we would standardize our work when we get all the data together. So thank you so much for this privilege, and over to you, Dr. Raman.
Thank you. I mean, amazing. I mean, that's the word which I always use. Listening to you, you have covered everything. In fact, Dr. Singh, everything. In fact, you don't leave anything for anybody to comment upon. But I would initiate the talk, the perspective on the talk. Before my other colleagues join in, just one thing which I would, and then we'll come back again, is how did you convince the physician to join and own? That is the toughest challenge one faces in implementation of AMSP in any institution. Because one can, even if one owns the hospital, and still the confrontations and the willingness is going to be terrific, and may at times lead to more harm than, so that's something which we definitely would like to know. And there are a couple of questions from the people we'll take later on. So before other colleagues join in, this is something which we all face.
Yeah, thank you, Dr. Raman. I think what work you have done in your institute and with HISI is speaks by itself. But I understand the question. You know the answer. Basically, I think it is important to collect data and keep engaging with them. The investment with communicating this data and facts, because you cannot win over clinicians by emotions, and it is important to keep engaging with them, keep sharing the data, keep sharing the fact, and once they see your honest representation and they see the larger game, we also need to understand their perspective, because a surgeon feels that for him or her, that particular patient is the most important and they would like to sort of save the life. Unfortunately, they feel that antibiotic being the wonder drug is what would save the life. So it is sometimes the peer audits help, sometimes some of the champions help, sometimes they being the champion, the one who is a major defaulter becomes a champion and he changes the behavior. So as I said, there are multiple strategies and we have failed. Many a times we also have failed because we realize that, like I remember a continuous insulin infusion therapy leading to reduction in surgical site infection. We have failed up till now. So we have not able to convince the endocrinology team and the rest of the critical care team. So there are many places where you do fail, but I think what is important is to just keep engaging, and the patience and the perseverance is the key.
Thank you so much. You said the right word, perseverance. So that is something which, over to other colleagues on the moderating team, please.
Thank you, Dr. Sanjeev. It's a very nice talk. And you did mention that earlier in your talk, different stewardship programs or different like policy and guidelines. You cannot make a unified one because the practice is different. And I can see from the map of Kerala you showed, they have so many like medical colleges, hospital, but even vast majority of them are private hospital. Do you see difference in the practice? And do you like when you want to establish any program for antimicrobial resistance, do you see like like an outcome? Is it unified? The measurement of the outcomes. Do you unify them? And what do you see in the practice of the private hospital? Is that difficult or is it easy to manage?
Thanks, Fahad, for that question. Very difficult question. What we have seen is Kerala is a different country within the country. So it has 99% of literacy. It's a health-seeking behavioral state. The primary and the secondary care is fantastic. So at times it is easy to implement, but I realize out of 35 medical colleges, there are 7 medical colleges which are public and rest are private. this is a state where the public sector gives equal competition in quality to the private sector. They are so good, they are so very well managed and quality driven that that you learn many a times from a good public sector institution. In Kerala, you learn in the private institution. The good point is that they're all sort of governed together by the Ministry of Health and the Director General Health Services, and then the adherence to the guidance which comes from them is easy. The bad point is that even if they don't do nothing, you cannot do anything about for them because it is a permanent job. In the private sector, it is a non-coherent group, and unfortunately they compete. But you could get a good collaborative together just in case, when your whole intention is honest. So what has been done in Kerala is getting all through professional societies. All of them participated for almost 2.5 years, and all medical colleges participated. So there is an ownership from all of them to make the program successful. And there is a phenomenal work which has also been done by WHO India to get the surveillance network. So it's a difficult question and a difficult thing to get people together. It was slightly easy because public participation and private participation was, as a strategy, it did work in the state of Kerala. But we are trying in other states. It is taking time, but I'm sure this is the only way to go.
So before Dr. Heather takes over, just one, this thing will take a question from Zaid Almai on the similar subject, where Zaid wants to know whether, on restriction antimicrobials, until unless the policy is also implemented in the private sector, it would always, it will never achieve the purpose for which, because they're likely to visit, the patient is likely to visit a private practitioner or a pharmacy, especially with OTC, So he wants to know whether you tend to agree with this, or you have some more ideas which have worked in Kerala.
I completely agree. So what we have also done at Kerala is looking at One Health approach. So we had banned colistin as growth promoters in animal husbandry. We had looked at antibiotic consumptions in fisheries. We are geotagging chickens in most of these farms, so it becomes very easy to monitor, though it is unfortunately it's so huge that it is difficult to. In environmental health, there is a lot of work which has been done. All the expired antibiotics, all doctors participate, brings the expired antibiotics and gives it to the IMA green box, so that it is all incinerated and it doesn't get into either a landfill or in water, creating more resistance. So I think it is important that we adopt a comprehensive approach and look at how private group also participate. But the Indian Medical Association and professional societies participation and getting creating more collaboratives and collecting data and sharing is the only answer to get the private participation in place for antibiotic stewardship.
Thank you, Dr. Sanjeev. So over to Dr. Heather.
Thank you. We really have a lot of interesting questions in the chat. First of all, thank you, Dr. Sanjeev, for a very informative and interesting presentation. It was really well put together, and I'm grateful to be a part of this group here. I want to build a little bit on what Dr. Fahad had said, kind of taking it a little bit further. As you know, here I'm here with the CDC regional office, so we work with 25 countries directly and indirectly in the region. So it's a really big region. And I'm wondering, what your thoughts are in terms of trying to build a network, a regional network to look at AMR stewardship. Do you think the key considerations that you raised in your presentation would be applicable, looking at issues around training and around the importance of ownership and public-private partnerships, or are there other things that we should be thinking about? Because I know we all learned during this past pandemic, or this current pandemic, however we want to look at it, in light of some of the earlier talks. I know, during the past 2 years, one of the big challenges was really trying to build out and work across countries. And so there are it's really clear that this is not an easy issue to tackle on a country level, but let alone on a regional level. So I'd be interested to hear whether you think that the considerations that you raised in your talk would be applicable on a regional level and in this context. Thank you.
Thanks, Heather. I think a very interesting question. In 2012, when we thought that there is a problem in intensive care and tertiary care hospitals, I thought of reaching out to the government and say that we all need to scale it up and work together so that there is a good rational prescription practices. The first thing which the government asked, is there any data? Why are you bothering when there is no data to say that there is a problem? And when we reached out to 1,000 physicians and did a survey, and we realized that our prescription practices are haywire, and it is extremely bleak. And what we are practicing, many a times we actually don't know the mechanism, and we are still sort of writing, though we consider AMR as a problem. We also reached out to the lab during this survey, and we realized that many of the discs are not available, but they are still testing. They're giving reports, and most of this is manned by microbiology technicians, and there are no microbiologists available. When we reached out to the pharmacists, almost close to 1,000 plus pharmacists, there is no connect between the pharmacy prescription and the feedback which needs to go to the clinicians, and over the prescription, despite of the fact that there is a red line campaign and there is an H1 gadget, there is no adherence to those norms. So all of this has been brought to the notice, and there is a lot of work which is happening at the government level and the private participation. So most of the hospitals now do follow an H1 publication where they take a dual prescription, though there is a lot of work to be done. So what I feel is that first important step is data collection, to understand that there is a problem, and that is what we need to share either with the public sector or with the rest of the private sector. Second important thing is definitely training, because unfortunately in India there is no renewal exams, and post graduation there is nothing which which builds your capacity. What I have also realized is training doesn't change behavior at all. So we need to look at many ethnographic tools where our pattern of infection control practices and prescription practices change. How do we do this? We need to create, as you rightly said, center of excellences and regional centers where people come, see, and actually believe that this is how you need to strategize, and this is what works. And then it is also important, once you create a center of excellence, it is important that institute like where Dr. Raman is there, they need to handhold at least 10 to 12 secondary care hospitals, because unless the few corporate hospitals improve, it is not going to make any difference. We need to create a ripple effect, and that is where I think we can contribute largely towards an AMR containment program.
Thank you. I mean, what you talk about is becoming a hub and then attaching other hospitals' programs to your own program. So that's a very good idea, in fact, with the hub and spoke situation. So thank you, Dr. Sanjeev. Dr. Fahad, Dr. Heather, you would like to ask something else from Dr. Sanjeev, or because the time is running short. So anything that you want to particularly bring about?
I don't know if you've been following the chat, and quite a few good questions in the chat. I don't know if
Yeah,
maybe we can keep those and circle back.
I think we'll pass on to Dr. Sanjeev, and maybe he can, keep on, answering them. So Dr. Prashant Gowda has asked about monitoring outpatient antibiotic prescription and establishing stewardship based upon that. So all such things, I think you can maybe reply on the chat if Dr. Sanjeev can spend some time.
Sure.
So yeah, with paucity of time, we wind up, and I thank Dr. Sanjeev Singh for an excellent lecture covering everything. You talk about nursing empowerment, which is very, very important, and we have seen the strengthening the AMSP from nursing is something which delivers. And we talked about you touched everything from my point of view that needs to be done and implemented firsthand. So thank you, Dr. Heather and Dr. Fahad, for being very understanding and precise questions, and bringing about the tough things from Dr. Sanjeev to answer upon. Thank you, everyone. Thank you, the audience, for great interactions. And once again, have wonderful times. So from all of us, on the moderation group for this first lecture. Over to Dr. Meher, please.
Thank you so much for that absolutely fabulous talk, which covered so many aspects. It's really mind-boggling, and you touched on all of them, and you've done all of them. So you really walked the talk. And Kerala, I love what you said. Kerala is a country within a country, and that is really very, very true. And to many more successes to you. And I hope we handhold all the other hospitals, as you said, and we bring in some change. Thank you so much, Dr. Sanjeev. Thank you, Dr. Raman, Dr. Heather, Dr. Fahad, for that excellent session. Thank you so much. Ladies and gentlemen, my laptop again had decided to play havoc with me, but yes, it's back. So from one excellent talk, we move to yet another one, and we have the erudite Dr. Pawan Kapoor, who will take a talk on patient safety initiatives and implementable solutions. And to moderate the talk, we have two eminent moderators, Dr. Reba Kanungo and Dr. Rahila Ahmed. Audience, please have some patience with our resource persons and moderators as they introduce our eminent moderators. We need to have incisive, cutting-edge moderation so that the talk's level can be elevated. So I welcome Dr. Reba Kanungo, and to introduce her, I welcome Dr. Adila Shaukat, Principal Investigator, Doha, Qatar. Please introduce yourself first.
Good evening, everyone. Thank you, Meher, and thank you, the organizers of this excellent symposium, to give me the opportunity to introduce Dr. Reba. I'm Dr. Adila Shaukat, Senior Consultant Infectious Disease for Hamad Medical Corporation, Qatar, and I am also Associate Professor of Clinical Medicine in Qatar University. I am ASM Country Ambassador to Qatar for the year 2022 to 2024, and I'm a part of Dash to Protect Antibiotic Study. So it's an absolute privilege to introduce Dr. Reba Kanungo, who is a very eminent and knowledgeable personality. She is a former Dean, Research and Head of Clinical Microbiology from Pondicherry Institute of Medical Sciences, India. And I have a great pride to shed some light on her work, her services and achievements in the field of microbiology. She's a former laboratory program advisor for the Center for Disease Control and Prevention, CDC Atlanta, USG GAP. She has provided technical assistance to NACO and SACS through US government partnership with Government of India, Ministry of Health and Family Welfare. She has undergone extensive training in innovative diagnostic tests in HIV at CDC Atlanta, and also she has gained training in National Laboratory Strategic Planning in African Center for Integrated Laboratory Training, Johannesburg, South Africa. She has also trained as a trainer for strengthening laboratory management towards accreditation in Atlanta, USA.
and she serves as assessor and coordinator and mentor for national and state reference laboratories assessments conducted by National AIDS Control Organizations, Government of India, and CDC USA. She has been a mentor and assessor for IRL and NRL TB testing laboratories, Central TB Division, and FIND. And she is also a former ASM India country ambassador from 2016 to 2022. So we welcome Dr. Reba with great honor in this prestigious forum.
Thank you so much. Welcome, Dr. Reba. And now I'd like to welcome Dr. Rahila Ahmed, who is one of our eminent moderators. And I welcome Dr. Shalini Malhotra to do the honors. Dr. Shalini?
Yeah, am I audible?
Yes, yes, you are.
Yeah, thank you, Dr. Meher. Good evening to one and all present here. I feel privileged to be part of this ongoing symposium on antimicrobial stewardship and patient safety initiative. I've been working as hospital infection control lead in AB WIMS and Dr. RML Hospital, India for the past 15 years as consultant microbiology. Today, I feel honored to introduce our esteemed moderator, Dr. Rahila Ahmed, who is Deputy Director Cedric, Senior Lecturer, Imperial College and City, University of London. She focuses on organizational change, economics, sustainability, and evaluation at the National Institute for Health Research, Health Protection Research Unit for Healthcare-Associated Infections and Antimicrobial Resistance. She is Knowledge Mobilization Lead at NIHR Health Protection Research for Healthcare-Associated Infections and the NIHR HPRU Respiratory Infections at Imperial. She is a co-investigator at NIHR HPRU Modeling and Health Economics. This builds on her prestigious NIHR Fellowship in Knowledge Mobilization, where she led research to evaluate sustained impact of interventions across the healthcare economy to address antimicrobial resistance. She is Deputy Chair for the Surveillance and Epidemiology of Drug-Resistant Infections Consortium, CEDRIC. This is a think tank designed to bring together a range of international experts to share expertise and take action to tackle the gaps in drug-resistant infection surveillance and epidemiology. A very warm welcome to Dr. Rahila Ahmed.
Thank you so much, Dr. Shalini. Dr. Shalini is a very close friend and a great colleague. And dear ladies and gentlemen, I am so honored to welcome Dr. Pavan Kapoor, who will be delivering a talk on patient safety initiatives and implementable solutions. To welcome him, I'm equally honored to request Dr. Reba Kanungo to please do the honors. Dr. Reba Kanungo.
Thank you, Dr. Meher. It's really been a pleasure to be invited to introduce such an eminent personality as Dr. Pavan Kapoor. I must at the outset thank you and the organizers for giving me this opportunity to be part of this wonderful initiative that you have taken in tying up a global program to look at the antimicrobial resistance, antimicrobial stewardship, and patient safety. Now, it gives me great pleasure and I'm honored to be introducing to the August gathering Dr. Pavan Kapoor. Dr. Pavan Kapoor, Air Marshal, retired AVSM, VSM, and BAR, former Director General of Medical Services, Indian Air Force. It's really indeed an honor to have a person from the defense, sharing your experience with us in patient safety. And what can be more pertinent than looking at safety of the population which you've been looking at, taking care of, and now we listen to you for the safety of patients. Air Marshal Dr. Pavan Kapoor is a hospital administrator of national and international repute. He is one of the founder members of the National Accreditation Board of Hospitals and Healthcare Providers, the NABH, and has been holding appointments as Chairman of Technical Committee and Chairman Accreditation Committee of NABH. He is a member of the International Society for Quality in Healthcare, ISQA, and is an international lead assessor for them. He had held the appointment of Commandant of Aerospace Medicine, the President of Indian Society for Aerospace Medicine, and Honorary Surgeon to the President of India with effect from July 1st, 2016 till December 31st, 2017. He is Vice Chairman of Reuse Education and admissions to medical universities in Russia, and visiting Vice Chancellor of Lincoln American University, Guyana. For his distinguished services, he had been awarded Chief of Army Staff Commendation thrice, Ati Vishist Seva Medal and Vishist Seva Medal twice, CAHO Lifetime Achievement Award, and AHA Ratna Award. He is also the recipient of his Order of the Royal Emblem of the Sultan of Oman while on deputation to SOLF from 1984 to 1987. With this introduction, I now request Dr. Pawan Kapoor to take us down the patient safety strategies, which is so very essential in protecting the patient and protecting the human race against the calamities that befall us through the irrational use of antibiotics. Dr. Pawan Kapoor.
Thank you, Dr. Riva. Good evening, good morning, good afternoon, salam alaikum, and to everyone who are here with us. My thanks to Dr. Meher Rizvi, to Sultan Qaboos University, to the American Society for Microbiology, the Hospital Infection Society of India, for giving me this opportunity to share my thoughts and my ideas about patient safety. Thank you, Dr. Riba, for such a wonderful introduction. And Dr. Meher, I think you have tried to put in too many people together and to come across and attend today's program. So special thanks to you. It's not very easy to get so many people together to come and discuss a subject of such a high importance today globally, not only nationally, but internationally. Before I begin, I must pay compliments to DASH project for protecting antibiotics. This is something, I think about 62 centers today participating in this. Their representatives are present here. There can be no greater national and international service nationally and globally than to protect your antibiotics. And all of you have come forward to do this. It is a Herculean task, but I always say that everything becomes difficult if you cry, but everything becomes easy if you try. And DASH is trying to make things easy for the future. So a lot of compliments to DASH. Myself, I feel like a small microbe in this galaxy of microbiologists and infection disease specialists, but I'll try to take you all on in my own little way on a very last subject of patient safety. Before I begin, I must say that most of the views that I express here are of mine. Those of us who have similar views, they share similar thoughts or may have read the same papers or same content somewhere. Whatever case studies I present in this are actual case studies which have happened on ground. So if anybody is familiar, please maintain confidentiality. And lastly, questions and comments will be asked for during and at the end of this session. If you don't ask, I will ask. So the anatomy of my presentation will be on what of patient safety, the why of patient safety, and the how of patient safety, what initiatives and what implementation can be carried out at our level, at local levels, at regional levels, at national levels, and at international levels. So let's move on to what. I don't know how you all take patient safety as and what you express as patient safety. I would say patient safety is freedom from unintended harm due to healthcare interventions, because I believe no physician wants to intentionally cause any harm to anybody. So patient safety is freedom from unintended harm due to healthcare interventions. For a period of time, patient safety is becoming a discipline which is emphasizing that data related to adverse health events and medical errors should be collected, should be reported, should be analyzed so that necessary corrective and preventive actions can be taken to ensure that these are not repeated. This is what WHO defines patient safety as. WHO says two things. One is you must try to reduce the risk of unnecessary harm to the bare minimum. And second is there should be absence of preventable harm. So what harm that can be prevented due to the process of healthcare, that should be zero. Preventable harm should not occur. And if there are certain things in which you cannot avoid, which are unavoidable and not preventable, they should be reduced to the acceptable minimum. Before I move ahead, I would like to take you to certain taxonomy. What is a patient safety event that may have or could have resulted in harm? And what are certain terminologies which we should be using over and over again? One is a near miss. A near miss says that a patient safety event which has not reached the patient. What does it mean? That supposing I have prescribed an antibiotic, and that antibiotic is required to be given after an antibiotic sensitivity test, and just in the nick of time before administering the antibiotic, we realize that the antibiotic sensitivity test has not been done, and we do not administer the antibiotic. This means a patient safety event could have occurred but did not occur, did not reach the patient. It is a near miss. Second thing is this: we do not do the antibiotic sensitivity test and we administer the antibiotic, but nothing happens to the patient, no adverse event takes place. In such cases, we say it is a no harm event where the patient safety event has reached the patient, but it has not caused any harm. And the last thing is an adverse event, which is, in which case the healthcare incident has caused an harm. That means you are given an antibiotic without doing the antibiotic sensitivity test, and that has caused an anaphylactic reaction. What is a sentinel event? The sentinel event is one where it has reached the patient and has resulted in any one of the following: either death or permanent harm or severe temporary harm. So these are certain definitions which we must know so that we learn to recognize patient safety events even before they occur and before the harm occurs or before they get converted into a sentinel event. Let's revisit some olden times. We all have taken Hippocratic oath, which says that we must prescribe regimens for the good of your patients according to your ability and your judgment and never do harm to anyone. And since then, the directive primum non nocere has become a central tenet for contemporary medicine, that is, first do no harm. So it is built into a system that we are not supposed to do any harm. Everything should be for the benefit of the patient. So why should we talk when everything should be for the benefit of the patient? Is there a need for us today to discuss patient safety? We say, no, it is not required, all is well. So let us see this cartoon. It says here that the rate of medical errors is stunningly high. The other patient says, well, that explains my hysterectomy. So obviously, all is not well. The message is loud and clear. Let us see by some data, is it true that all is not well? So let us see the whys. This is a WHO fact file. 1 in 10 patients is harmed while receiving hospital care. 1.4 million patients worldwide suffer from healthcare associated infections. In developed countries, the rate is around 5 to 10%. And the risk in developing countries where data is not collected, not analyzed, not reported is almost 2 to 20 times higher. There are 70% reuse of unsterilized syringes, and unsafe injections are causing 1.3 million deaths each year. 50% patients requiring surgery in developed countries die or have disability due to unsafe surgery. And 50% of medical equipment is unusable or partially usable. Chance of harm of air travelers is 1 in 10 lakhs, and chance of getting harm during healthcare is 1 in 300. There are 100 near misses for every adverse event which results in patient harm. And 37% of adverse events are highly preventable. And if you see the data on percentage of diagnostic and therapeutic errors in those countries where there were reportable systems, where they collect data and they have data analytics, you can see it is varying from 22 to 34%. So I will now present some of our very own case studies. I don't know, you may be familiar with them or not, but you will try to be with this case study to see that yes, sometimes in our career, these events have happened. This is a 30-year-old lady undergone a laparoscopic hysterectomy in a hospital whose OT has just been repaired. And a tile from the false ceiling of the OT falls on her outstretched hands and she sustains fracture of the lower end of radius. Now imagine the relatives have sent her for a hysterectomy and she comes out with a plaster on her hands. What impact it will make on the patient, on the relatives, and the rest of the people who are sitting there. Second is another 55-year-old lady who has undergone coronary artery bypass graft surgery and currently in ICU. On the second post-operative day, she shows features of restlessness, anxiety, and inability to sleep. Very common post-operative behavior in case of patients undergone CAB and in patients admitted in ICU. Nursing in charge rings up the doctor at 6:30 p.m. and doctor advises 10 milligram of compost to be given orally. The lady visits the toilet. There is a time for turnover of the hospital staff at 7 p.m. and the turnover policy says that all medicines prescribed during a shift should be administered during the shift. The nurse visits the patient bed. The patient is not there on the bed. The nurse visits the patient in the toilet and gives her 10 milligram compost IV. Very dedicated, very committed nurse. And the next thing that what happens is that when the nurse change comes and looks at the bed, she finds that bed empty. She goes to the toilet and she finds the lady is in deep sedation on the floor with a lacerated wound forehead. Two ladies, both aged 28 years and both named similarly, that is Leelavati. One has come for cervical ligation for recurrent and midterm abortion, and another one has come for dilatation and curettage and evacuation for MTP. The procedures get reversed because of similar names, and you know how heart-rendering this situation is for both of them. Again, certain lab investigations of fasting and postprandial blood sugar and lipid profiles, they continue to show higher readings. And many patients have been put on anti-diabetic and statin treatments till one of the affected individuals get investigated from another lab, and he says that my other lab has said that my status is normal. How are you putting me on these drugs? When you investigate and you find that the equipment of this lab has not been calibrated at all, and also the reagents are expiry date. This has happened to one of our Air Force pilots, admitted with fracture avulsion of a distal phalanx left ring finger, taken up for surgery in a tertiary care hospital. After surgery, when the patient woke up, he found that he has got more pain in left middle finger than left ring finger. So now the surgeon reveals that he had accidentally explored the left middle finger initially, and subsequently realizing that he has made a mistake, he did the corrective surgery on the right. Okay, on the right finger, on the left ring, this thing, ring finger. Now another 65-year-old patient who had undergone transurethral resection of prostate. He was going repeatedly to the toilet. It is very common to check out the flow of his urine. And on one such visit to the toilet, he slipped, fell, and sustained fractured neck of femur. This is a very, very sad case study. A 47-year-old lady who had undergone hysterectomy 2 months ago reported with frequent bouts of fever and pain in right iliac fossa. Ultrasound revealed fluid collection and query of foreign body. The lady was taken up for laparotomy and they found a pus-soaked gauze piece adherent to the colon, which was removed along with a piece of the ascending colon. The matter did not end here. The same lady comes back to the hospital 2 weeks after discharge with the same complaints and similar ultrasound findings. Laparotomy revealed another retained gauze piece. We did not learn from our errors. And what error took place? This is a classical case of counting error by the sponge counting nurse. 8 gauze pieces had gone in and 8 had been accounted for. That included the one which was removed. So one was left behind. You see how a simple error can result into a sentinel event. This is one of those case studies. A physician writes an order for adding primidone, that is misoline, to the existing medication for a 12-year-old boy with a seizure disorder. Misreading the physician handwriting, the pharmacist mistakenly dispenses prednisolone. For 4 months, the boy receives prednisolone along with his other seizure medications, causing steroid-induced diabetes. And this child, unfortunately, goes into diabetic ketoacidosis and dies from it. Now, this is another classical case of communication error, which I want to discuss with you all. See, what is the very simple thing? 55-year-old paraplegic mother on a wheelchair in a paraplegic center was given an outpass to spend a day with her daughter, who was explained that her position has to be changed every hour to prevent decubitus ulcers. When this lady reports back in the evening, the nursing staff who had tended to her for almost 3 months discovered to their horror that the sanctity of the sacral skin had been breached. Now, what happened in this case? On inquiry, the doctor expressed surprise because she said she had been moving that wheelchair every hour. Now, instead of telling the daughter that she's supposed to move the mother change the position of the mother every hourly, she understood I have to change the position of the wheelchair every hourly, and this is what happened. So let us go back and think when healthcare technology and all these things did not exist. Life was very simple, you know. To take history, do some inspection, do some palpation, do auscultation, get some basic lab results done, and do the treatment. Practice of medicine was simple. Maybe it was relatively ineffective, but was very, very safe. We were never taught patient safety in our medical schools. Not that it is being covered now, but patient safety was not even considered in our practice in the earlier stages. But with the advent of research and healthcare technology, what has happened? Babies are dying in the incubator. Government are filing complaint against faulty X-ray machines. Many incidents have evolved where the battery-powered defibrillators and monitors have failed to discharge during cardiac emergency responses. You can see repeated news: incubator turns furnace, 5 infants killed in incubator, fire in hospitals, superbug discovered, irrational use of antibiotics, causing ICU to become centers of superbugs. Avoided confusion everywhere. Everything is, marketed in the same way, so you don't know what drug you are prescribing. This is the state of affairs in the operation theater. So is there a mismatch now between technology, between us, between our knowledge, and between what we apply? Now practice of medicine has become complex. It is probably more effective than what it was in the past. So many diseases have been eradicated. The lifespan has increased, the life expectancy has gone up. But maybe practice of medicine has become potentially dangerous too. And are we not, like you said in the first slide, are we not going back to the pre-antibiotic era? Diathermy, surgeon and patient, you see the cautery burns that occur due to diathermy. Patients are falling off from stretchers. Yeah, other sample problems, one of them happened in front of me where a motorized table, while operating, the head end of the motorized operation table broke, but by luck, the patient neck was saved due to the presence of mind of the resident anesthetist. What I've told you is just tip of the iceberg. What lies beneath is massive because we don't have the data. We don't know what is happening. How much unsafe our patients are. But it has been said that doctors are more dangerous than guns, and it can be statistically proven. Number of doctors 70,000, accidental death cost by doctors per year 120,000, hence accident per year per doctor is 1.714, courtesy USA Department of Family Welfare. FBI gives this data, number of gun owners 80 million, accident death due to gun 15,000, accident per year per gun 0.0001875. Therefore, it can be easily proven that doctors are 9,141 times more dangerous than gun. What does it mean? Are we callous? Are we careless? Are we casual? Or just we are not concerned? When mistakes happen, this is the mantra that we should follow. Keep your fingers on your lips. Nobody should come to know. Push it under the carpet. Who is responsible? Doctors, nurses, other staff? I don't know. If I had a live session, I would have put to vote. Mostly, most of you would have said that it is all of them. But my take is that it is none of them. Why? Because it is a systems failure. And the systems failure arises from the fact that we discuss, we deliberate about patient safety, but do nothing about taking initiatives for improving patient safety and delivering quality of care. So if you see this question, I would have asked you in a live session this question, but I'm not going to ask you this question, that if in a hospital like this, where you're having repeated cases of blood transfusion reactions due to incompatibility, where patients are falling leading to injuries, where wrong side surgery has been done, and a medication dosing error leading to patient that has occurred, what could be the most probably single underlying cause behind these events? I would have no hesitation in saying that in this hospital, there is a systems failure. And why human beings, they make mistakes? Because the systems, the tasks and processes they work in are poorly designed. So the aim of my today's talk is to ensure that we design our system, tasks and processes in a manner that our professionals, our paraprofessionals, our nursing staff do not commit mistakes. So what we need to do, the how. When we make mistakes, we must look into the mirror, we must introspect, we must report, and we must take an action, we must prognosticate, we must plan, make policies, and we must perform as per those policies. Why are we here? Because of this reason. We have to plan, make policies, and perform. See, the current environment, we have seen that errors continue to occur and recur. We do not take action on the risks. We do not like to detect because we are shrouded with mystery and defensiveness. So therefore, most of the events are not reported. Therefore, we don't understand the causes of occurrence of those events. Therefore, we cannot measure the impact in our hospitals and across the country on that event. And whenever something is discovered or diagnosed or reported, we blame somebody who did it and we penalize that person. So blame culture is alive and well. This is the current environment. But why we are here? We are here to create awareness, to say that we are willing to change our attitude and our behavior. We are going to identify the problems and challenges as to why patient safety incidences are occurring. We are going to understand the causes. We'll develop solutions and system solutions, not individual specific solutions. We'll implement those changes based upon these solutions. We'll embed those changes in everyday practice so that it becomes a routine, well-oiled affair, and we monitor for effectiveness. This is why we are all here together. Patient safety is just not about statistics, but it involves damages to the lives of real people. And therefore, patients have to be at heart of all patient safety initiatives. Here are some of the initiatives. WHO has taken initiatives. We have certain national initiatives in all governments. In India, we have got national initiatives taken by the National Education Board for hospital and healthcare providers, where we have a patient safety framework, a patient safety goals, and we also have proper hospital infection control, standards. There are local initiatives like this initiative taken by you for DASH to protect antibiotics, the initiative taken to get all of us together and for us to share our experiences. These are all local initiatives. I will focus on some WHO initiatives based upon the World Alliance for Patient Safety. And most of us are signatory to this World Alliance as member states. They have said these safety challenges. There are about 12 action areas. I will only discuss 2 action areas. The first action area is clean care is safer care, safe surgery saves lives, and tackling antimicrobial resistance. These are 3 most important global safety challenges which we all have to come together, and we are taking steps like this step taken by Sultan Qaboos University. Is a wonderful step, and this is to protect antibiotics. That means you're going to in future tackle these antimicrobial resistance. Then next is to engage the patients. If the patients are not engaged, because what patient does, he goes to the private practitioner, he says, okay, I have been having fever for 3 days, I'm having these issues, and he expects you to prescribe an antibiotic because he has read somewhere that the antibiotics are to be given. And you don't give him antibiotics, then you are not a good private practitioner, he will go to somebody else. So patients have to be engaged, and only then we can actually look at patient safety, by engaging patients for patient safety. So they have to be involved in all aspects of safety. There are certain international patient safety goals that relate to patient identification, effective communication, medication management, safe surgery, healthcare associated infections, and patient harm from falls. So we should have our own national framework for patient safety. We should create awareness by having more such webinars, more such workshops, and take very simple measures in our own hospital for patient safety, which I'll tell you shortly. These are the doctor's toolkit for patient safety. I call them, these are simple measures which will save lives, which will save embarrassment, and which will save you litigation costs. The simplest thing is accuracy of patient identification. So have 2 identifiers with ID bands with your admission discharge number, and you can elicit the patient name from him or her. These are some examples of identification based bracelet. The second most important thing is taking care of communication errors. There are many errors. I told you there were certain verbal orders given by giving compost orally, they gave intravenously, and also how that girl moved the wheelchair instead of the patient. Most communication challenges do not have a life and death situation hanging in balance. But in healthcare, every conversation can have that life and death situation balance. 70 to 80% of our medical errors are related to interpersonal communications, and 63% of sentinel events occur due to communication breakdown. So we must improve communication. We must have bedside patient handover, not only on documents. Yes, you must document in the appropriate tool, but bedside patient handover is important. You must repeat and record all telephonic and verbal orders. Capitalize your drug orders, have good prescription practices which are legible, and use only standardized abbreviation. I will tell you, I was shocked to find somebody writing FeSO4 1 TDS. Now, if you do not know what FeSO4 stands for, you don't know what drug the patient is going to get. Incidentally, he wanted to give ferrous sulfate. Again, critical alerts should be communicated and they should be followed up to complete the route. If there's a critical alert value, that is abnormal lab values or X-rays, they should be immediately informed to the licensed caregiver, which can be vital for patient safety. Then improve medication management practices, that is follow the 6 hours right medicine for the right patient at the right time and the right dose in the right by the right route by the right person. So write legible prescriptions. Be aware of look-alike and sound-alike drugs. Do not store them together like Roxin and Roxin, ROKCIN and ROXIN. One is an antibiotic, other is a thyroxine hormone. Havoc can take place. Please label the high-risk medications and label all medications in various containers. You can see how look-alike drugs can create havoc here. You see how prescription can be made in the pharmacy. They keep these boxes for prescribing. This is for this, this is for this. This I've already told you. Another important thing is reduce the risk of healthcare associated infections. So CDC has said very clearly, wash hands for at least 15 seconds. You might like to sing happy birthday to yourself while washing your hands. You can use waterless hand cleaners when soap and water are not available. Don't wear artificial nails in patient care areas and know when to use the correct hand hygiene. These 5 moments, I think everybody knows, seldom practiced in many areas. We have done so much analysis. The compliance is never more than 65 to 70%. And these 5 moments are before your patient contact, after the patient contact, before doing any aseptic task, and after coming into touch with body and fluid exposure, and after contact with patient environment. The certain pillars of HIC program, I will not go into these pillars in detail because they are themselves a separate talk. One is to have a hospital infection control manual. That manual should address standard precautions with focus on hand hygiene. It should address the disinfection and sterilization practices. It should address OT and ward practices. It should address antimicrobial usage policy, the rational use of antimicrobials, the antibiotic stewardship program, and antibiotic prophylaxis. If all this is addressed, most of the problems of healthcare associated infections can be controlled. The last one is risks from harm from patient falls, and that you can put some sign like a leaf magnet, something, so that everybody knows that this patient is a risk for fall. So they will try to make sure that the patient is safe and secure. Implement surgical safety checklist. I am sure most of you know the WHO safety checklist for sign in, time out, and sign out. So at the time of sign in, you must confirm the patient identity, the procedure, the consent, and the site. Site is marked if it is applicable. Anesthesia safety checklist is completed. You must ensure that pulse oximeter on patient is functioning. Does the patient have known allergy, any difficult airway? Is there risk of blood loss? All these are taken into consideration at the time of sign in. At the time out, everybody must identify themselves, must understand their roles, must anticipate the critical reviews both by the surgeon and the anesthetist and the nursing team, and then check for antibiotic prophylaxis whether it has been given and is essential imaging displayed or not. So that pilot who had the wrong operation, he would not have had this operation if the imaging had been displayed. In time out, in sign out, the nurse verbally confirms with the team whether the specimen has been labeled, the procedure has been recorded, instrument sponge and needle counts are correct, and surgeon, anesthesia, and professional nurse review the key concerns of the patient. The last simple measure is all that you can do. You can have risk management committees to identify, do risk assessment, do employee training, lay down policies for biomedical waste management, Have process management like frequent fire and disaster drills, safety around prescription, nursing and clinical audits to arrive at various problems that are being faced by these audits. Do inspection of all your equipment before you are embarrassed or before an adverse event reaches the patient. Daily questions you ask, what did you do well today? Replicate it. Any harm that occurred? Then if patient care, past harm is taking place, presently is the patient safe from that harm? And are our clinical systems and processes reliable? Daily question to ask yourself before you go to your workplace and start doing your work. Is care safe today? Will care be safe in the future? And are we responding and improving? That means, are we learning from our experiences? These are very important questions on a daily basis. Employees, they must report any potentially dangerous patient situation to the supervisor. They should participate in performance improvement processes in the department and take their annual mandatory training seriously. And if there is no training, please, this training should be introduced. It will help you to at least identify the safety issues. Please do not take shortcuts. Whenever you take a shortcut, rest assured a mistake is going to happen. Use your checklist. Ask your co-workers to complete double checks and allow patients to participate in own care. Yes, patients, what they can do for their own safety, they must participate in own care, give honest disclosure, follow instructions. When in doubt, seek clarification. Don't be your own doctor and report for follow-up as scheduled. Should not be like this that I have searched every book, also the internet. So in desperation, I have come to you, doctor. And this also should not be there. The doctor should not tell the patient that when we want your opinion, we will give it to you. So the final words are, we have to all be an advocate for our patients. Patient safety is everyone's job. When things go wrong, please document, quote the sequence of events. Do not rely on your memory, quote the truth, only then we will learn. So we have to prognosticate, we have to plan, we have to make policies, and we have to implement those policies. If we don't do this, then we know for the want of a nail, a horse was lost, for the want of the horse, the warrior was lost, for the want of the warrior, the war was lost. In India, hospitals have been burned, people have been beaten up, there have been litigations, there have been resistance, there have been a lot of protests and strikes. So would you like to be this tomorrow when you go to the hospitals? Would you like this to be your regular staff? Would you like this to be your personal limo? Or you want this person to be barking away to be your official spokesperson? I'm sure you don't want anything of this sort. So take these tips. Constitute patient safety committee in your hospitals. Develop policies and protocols based upon your identified patient safety and risks. Orient and reorient hospital staff. Encourage transparency and non-punitive incident reporting by staff. Rather, you should award them for reporting incidents. Each department should devise their own safety protocols. Each investigation of each patient safety incident should be investigated for taking corrective and preventive actions. And regularly we must monitor, review, and evaluate our safety procedures. So final take-home message is that errors are common in medicine. They make killing tens of thousands. We begin to know something about the epidemiology of error, but we need to know much more. Naming, blaming, and shaming have no remedial value. We need to design healthcare systems that put patient safety first. We know a lot about how to do that. All we need to do is to take initiative. Remember that simple measures will save lives. Remember the measures. Remember that compassion, human touch, and empathy existed. They must continue to exist. Remember that bad systems, not bad people, are responsible for most errors. So do remember you have to change the system and propagate safety culture, a people-based patient safety. Also remember to take the lead and make healthcare safer. My request to you is, please remember to remember whatever you can remember. And this is for you, Dr. Meher. You have always wanted me to say this, so I'm saying this for you. And don't say we have no time. We have every material thing with us to be happy, but for being truly happy, we have no time. We have led a fast-paced life, but for living our own life, we have no time. We are aware of the lullabies that our mothers have sung for us, but to call our mothers, we have no time. We have the numbers of all our friends in our mobiles, but for friendship, we have no time. What do we say about others when for our own self, we have no time? Our eyes are drooping for want of sleep. It is late night in India, but for falling asleep, we have no time. Our heart is full of sadness, but to share our sorrows or shed a silent tear with someone whom we love, we have no time. We keep running in pursuit of wealth, but for rest, we have no time. How we can appreciate others when for our own dreams, we have no time. We have attended a talk on antimicrobial stewardship program and patient safety, but for implementation, we have no time. Thank you very much for your patience, perseverance, and promise to remember. I will not take the quiz because I have no time. Thank you very much. I have finished. I'm sorry, I must have exceeded my time.
Thank you, Dr. Pawan Kapoor. It was a really enlightening, exhaustive, detailed addressing of patient safety, which I'm sure everybody must.
Yeah, I think we are lost to Dr. Reba.
Yes, unfortunately, that looks like that. Till she joins in, thank you, sir, for that immensely inspiring and fantastic, as well as, I can't say hilarious, but something which made me laugh all through, and that is the quality which Dr. Pawan Kapoor you have. You talk about the most difficult topics, and yet you make it so human and you make it so relatable and something which we can actually translate into practice. I hope that our other moderator is here to take up from. Yes, Dr. Zahida, please.
Thank you, Dr. Meher. So thank you so much, Dr. Pawan. That was really interesting and helpful how you managed to get in the large data, but also the personal stories. And I think that's the bit that's so powerful. The question I have really relates a little bit to your very interesting biography, coming from a military background as well. So the question I have is kind of a big question for us to think about, but really interested in your thoughts. When we have industries like airline, the military, oil rigs, etc., and we have a safety failing, that one incident reflects really badly on the whole of that industry. And there seems to be something of a collective responsibility to respond. And we see that now in all of those industries. Yet when there's a safety failing, major ones, in healthcare, we seem to scatter and we don't come with a collective response as an industry. Can you please tell us how we can learn from the military and these other industries and how we can have a collective responsibility and response so that we can maintain trust in healthcare as an industry? Thank you.
Okay, thank you, Rela, for a very wonderful question. I think, see, I come from the Air Force, and in Air Force, the safety of the aircraft is of prime importance. And we keep on saying that we do not have. We keep on saying we have almost, our healthcare industry has errors equivalent to 10 Boeing crashes every month. That's what the common statistics tell us. We don't know how far it is true, but I would like to here deviate a little bit from the question that you asked me. I want to tell you, see, in healthcare, in our industry, the patient is the fulcrum. And the patient goes through not one person. He goes through a whole spectrum of persons, right from the receptionist to the super specialist. So the people who are handling him, there are many people. And as you know, when you are, so many people are handling the same equipment or the same patient, the chances of error at every level of interaction will keep on happening. So the problem arises that we have errors at every place, and we have now to pick and plug those holes in every interaction of the patient at every level. That is why I said patient safety is everybody's job. It is not only job of the doctor or the nurse, it is the job of every employee, including the maintenance staff. Now, what happens in the aviation industry? So what happens in the aviation industry? There's a checklist for the ground staff. There's a checklist for the crew. There's a checklist for the air staff who is looking, that is the air hostesses. Everybody has their checklist. More than the checklist, they have to sit down and verify each and every item of the checklist and tick it. They can spend more time in doing it. They can delay the departure of the aircraft, but they will not move forward until unless the checklist has been corrected and correctly ticked. There are no shortcuts. First thing. Second is the crew resource management. In crew resource management, I have seen with my own eyes a lieutenant who is in the first rung is telling a vice marshal who is somewhere equivalent to major general in the army that, sir, you are wrong. He can tell this because he knows that if he doesn't tell him, then the aircraft and everybody in the aircraft is at risk. So this reverence for seniority, this reverence for experience should not be at the cost of reverence for evidence. So in healthcare industry, we should look at evidences. Experiences matter, but experiences should not be at the cost of evidence, at the cost of evidences. Therefore, in healthcare industry, we need to have a collaborative and a cohesive response to patient safety incidents rather than pointing a finger as somebody who has become the second victim of a patient safety incident. The second victim is the person who has committed an error. He becomes an outcast. He is fined. He is everywhere disgraced. He is shamed, and he has to pay out a whole lot of sum of money. Instead of doing that, if you are looking to at what made him commit that error, go to the what and how and not who has done it. If we all get together and come together as a healthcare industry as a whole, I don't think I should call healthcare an industry, but as a healthcare setup as a whole, and we try to remain together and not castigate a person who has committed some error, but try to find out ways and means of overcoming the error, I think we can definitely learn from other industries and move ahead of them because we have that commitment to our patient. We don't want to lose a patient.
Thank you, Dr. Pawan, and hopefully these other industries might in time learn from healthcare, we hope. I think Dr. Reber is back.
Yeah.
Should we move to Dr. Reber?
Yeah, hello? Yeah. Can you hear me?
We can hear you.
Hi, can you hear me?
Yes.
Yeah, okay, sorry. I'm so sorry about that. I lost connectivity as usual, you know. Dr. Pawan Kapoor, I had a question to you. My question was that since the patient, as he or she enters the hospital, passes through various instruments, as you put it, would it be, what would your idea be on, starting to train each of these healthcare professionals in terms of patient safety and accountability?
Thank you, Dr. Reba. Yes, I had somewhere covered it in my presentation. I will come back to that point again. You see, we need to introduce patient safety in the curriculum of undergraduates in medical colleges, in nursing colleges, in paramedical schools. We must tell them that they are all, they are all a part of a system where any error on their part can result in more worse repercussions on the patients who visit them for whom they are being trained. So I am for one very clear on this. We must introduce patient safety in the undergrad curriculum of all professionals. We must also take into consideration even those sanitary staff, the housekeeping staff. They should not be told you're just here for cleaning. They have to be told that your cleaning makes a difference. You are a mini doctor for the patient because your cleaning makes a difference in preventing healthcare associated infection. You must tell the same thing to the laundry guy that whatever linen comes to you, it has to be cleaned properly because this also contributes to patient safety. You are a mini doctor. So if you tell all your level of staff that you are mini doctors, this training is essential for you, they will get that requisite boost that they are also contributing to the ultimate care and cure of the patient. So I think training is a very important activity.
Yes, thank you. Thank you, Dr. Pawan. Any other questions or I don't see any. Everybody is very impressed with your detailed expose of patient safety, Dr. Pawan Kapoor. And I must thank Dr. Meher for thinking about this topic as part of this initiative of NASH. And it really is very crucial that every individual is aware of patient safety. Thank you very much for your detailed talk, Dr. Kapoor.
Thank you.
Thank you so much.
Thank you. Thank you.
Thank you so much, Dr. Pawan Kapoor and our moderators, Dr. Reba and Dr. Rahila. The entire audience was left enthralled. As usual, Dr. Pawan Kapoor, I think that's no news to you. You have and will continue to enthrall audiences and I'm sure motivate them towards patient care, better patient care and accountability. And with your excellent take-home messages, I think we're all inspired. Thank you so much. And ladies and gentlemen, we move to the other talk, the final and yet one of the most important talks for today. I welcome Dr. Arjun Srinivasan, CDC cap from CDC Atlanta, who will be talking on propelling antimicrobial stewardship post-COVID, harnessing public awareness and individual responsibility in judicious use of antibiotics. I welcome two eminent moderators, Keith St. John, Mr. Keith St. John and Dr. Anush Sharma, to please take over. To welcome Keith, one of my mentors, shall I say, through Shay, I would actually wanted my own mentee to welcome you, Keith, but the problem is that it is raining cats and dogs in Aligarh and the connectivity is bad, there is no light, and it is my honor to welcome you. So Keith is an amazing person. He is a hands-on infection preventionist for the past 30 years, including 17 years of directing IPC programs at major tertiary teaching institutions like Temple University Hospital, Children's Hospital at Philadelphia. He is former Vice President, Clinical Affairs at PDI, located in Woodcliff Lake. He is certified in infection control and epidemiology and is a past president of Certification Board of Infection Control and Epidemiology. He is a fellow at APIC Academic Training. For more than a decade, he served as a member of United States Pharmacopoeia Convention Expert Compounding Committee and is a co-author of several chapters of the USP on pharmaceutical compounding. He has served on the editorial board for the American Journal of Infection Control. Mr. Keith St. John was awarded the SIS President's Medal for exemplary service to the society. He is an amazing individual and an amazing mentor, and it's an honor to introduce you, Keith. The last and the most important eminent moderator of today is Dr. Anush Sharma, who has done some fantastic work in a whole lot of countries, and of course, closest to our heart is India. To welcome him, I request our principal investigator from Peshawar, Pakistan, Dr. Maria Khan to please do the honors. Dr. Maria
Thank you.
Khan.
Thank you, Dr. Maher, and good evening, everybody. I'm Dr. Maria Khan, basically working as a consultant microbiologist, assistant professor at Ahmad Medical Institute, Peshawar, Pakistan. And I'm so pleased to be here with you, and it's my great privilege to introduce our next distinguished moderator for the evening, Dr. Anuj Sharma, who is currently working as a technical officer, antimicrobial resistant health laboratories, infection prevention and control for the WHO Country Office, India. It was a defining experience when Dr. Sharma worked as a public health professional with more than 18 WHO country offices, 2 regional offices, that is the South Asian and Western Pacific regional office, as well as the WHO headquarters on development of national policies, strategies, action plans, and technical guidance on antimicrobial resistance, laboratory strengthening, and IPC, and as well as e-health. Coupled with his impressive background, he has facilitated the development of Indian National Action Plan on AMR, that is the Delhi Declaration on Antimicrobial Resistance, and 3 state action plan on AMR for Kerala, Madhya Pradesh, and in in Delhi. Also, he has supported AMR initiatives in Nepal, Indonesia, and Zambia. Furthermore, he has coordinated the establishment of 3 state surveillance networks in Maharashtra, Kerala, and Delhi in collaboration with state governments and Indian Association of Medical Microbiologists state chapters. On behalf of our organizing team at Sultan Qaboos University, Oman, I welcome Dr. Anuj Sharma.
Thank you so much. Thank you so much, Dr. Maria. And ladies and gentlemen, we're really excited about inviting and listening to Dr. Arjun Srinivasan's talk. He is an absolutely amazing person. And I welcome Keith St. John, Mr. Keith St. John, to please welcome Dr. Arjun Srinivasan.
Well, thank you so much, Dr. Mayer, and thank you for this wonderful opportunity to be a co-moderator with Dr. Sharma from the WHO. It's my distinct pleasure to welcome Dr. Arjun Srinivasan, a friend and colleague for sure. He is the captain in the U.S. Public Health Service, Deputy Director for Program Improvement at the Division of Healthcare Quality Promotion, the CDC in Atlanta. And he is board certified in infectious diseases. Before coming to CDC, he was an assistant professor of medicine in infectious diseases in the division of the Johns Hopkins School of Medicine, where he was the founding director of the Johns Hopkins Antibiotic Management Program and the associate hospital epidemiologist. His primary responsibilities include oversight and coordination of efforts to eliminate healthcare-associated infections and reduce antibiotic resistance. His research and investigative areas of concentration have included outbreak investigations, which I was fortunate enough to collaborate on one of those, infection control, multi-drug resistant gram-negative pathogens, and now focus on hospital antibiotic stewardship. Dr. Srinivasan has published more than 100 articles in peer-reviewed journals on his research in healthcare epidemiology, infection control, and antimicrobial use and resistance. And I must say he is considered one of the key opinion leaders in this topic of antimicrobial stewardship. So let's welcome Dr. Arjun Srinivasan.
Thank you all so much. Thank you, Dr. Sharma. Thank you, Keith. And a huge thank you. Let me share my screen here. Huge thank you to Maher for giving me the opportunity and for all the work that she's done. We have such a debt of gratitude to her for her tremendous leadership in this effort. Let me confirm, can you all see the slides properly? Keith, can you see these?
Yes, I can see them. Yeah, you want to put it in presentation mode though.
Is it not? Okay.
Yeah,
Is
it's
it
not
in
on presentation. Not yet.
Oh, let's see. Why is it not?
Use the book. There's a book icon, maybe that will work. Yeah, the next one. The one, yeah, this one. Yeah, I hope this works.
The next one is
yeah.
Yes, just click on this.
Yes, okay. How's that?
Yes, yes. Please start.
Yes.
Okay,
Very good.
excellent. Very good. Okay, fantastic. Thank you all so much. So apologize for the technical delays. So, I think it's important for us to talk a little bit, when we talk about the post-COVID world of antibiotic stewardship, begin by looking a little bit at what happened during to antibiotic use and stewardship during COVID. And interestingly, in the United States, we did not see big changes in overall antibiotic use during the COVID pandemic. So this is a graph showing total pooled mean rates of antibiotic use in US hospitals, 746 hospitals that share their antibiotic use data with CDC. And this is showing you 2019, 2020, and 2021 to give you a sense of the impact in 2019, pre-pandemic, and then post-pandemic in 2020 and 2021. And you can see there really was not much change, very slight variations around the baseline, even a suggestion of lower antibiotic use per 1,000 patient days during the pandemic than before the pandemic. However, that high level view of total antibiotic use does hide some important differences that we saw in the use of specific agents. And in particular, ceftriaxone and azithromycin. The graphs look very similar, so in the interests of time, I'm just going to show you ceftriaxone here. But here now you begin to see that, yes, there were some significant increases in antibiotic use during the COVID pandemic. Look at ceftriaxone. Again, you can see here during the winter wave of COVID in 2020 into 2021, you see significant increases in the use of ceftriaxone. Again, not unexpected, because that's what people would use to treat cases of pneumonia, which sometimes COVID can mimic. And again, you see that use begins to go back down to closer to baseline in the springtime of 2021. But then here on this graph, you see the Omicron wave, July of 2021, and ceftriaxone use again begins to rise. We did see major impacts on antibiotic prescriptions in the outpatient setting during COVID. Of course, a reflection of the fact that many people stopped going to outpatient clinics. Many clinics closed during the early part of the pandemic. You see here this cliff that happened, that antibiotic prescriptions from outpatient pharmacies in the United States, they literally drove off a cliff at the start of the pandemic. And then that was really sustained for quite some time. It was close to a year before outpatient prescriptions began to start rising again. And we have seen these get pretty close to back to where they were pre-pandemic, but it's taken a very long time for that to happen. We do, however, just as we saw in the hospital settings, if you look at outpatient prescribing, when there is a wave of COVID, antibiotic prescriptions go up in correspondence with that wave, as illustrated here. In nursing homes, we see a very similar picture. When you look at total antibiotic use shown in the green line at the top here, pre-pandemic and then post-pandemic and during the pandemic, 2020 and 2021, there are not major changes. And in fact, there is a suggestion of even slightly lower antibiotic use during the pandemic. However, when we look again at ceftriaxone and azithromycin, we see these massive rises, even more prominent than in hospitals, huge rises in azithromycin and fairly large rises in ceftriaxone as well, every time there is a COVID wave. There's, I think, some encouraging signs here. The waves, the rises in ceftriaxone during kind of subsequent COVID waves were much less than in the initial COVID wave. However, those increases still were quite significant. It's the impact on antibiotic use, but what happened to antibiotic stewardship programs? So this is a very nice survey that was done in Michigan of Michigan, over 50 different hospitals, asking the stewardship programs, what happened to your traditional antibiotic stewardship activities during COVID? Did they decrease somewhat or a lot? And as you can see, in all but one hospital, the traditional antibiotic stewardship activities either somewhat decreased or strongly decreased with the advent of the pandemic, which of course makes sense because antibiotic stewardship programs were pulled into managing the drugs for the pandemic, pulled into helping develop treatment guidelines, which had to be updated on such a frequent basis. So they did not have time to focus on the core antibiotic stewardship work. And you have to wonder how much of those increases in ceftriaxone and azithromycin we saw in hospitals were a reflection of the fact that our stewardship programs were pulled out of their duties and had to work so much on managing COVID therapeutics. There is also a lot of burnout and fatigue among our antibiotic stewardship program staff. This is an assessment of what's known as a burnout symptom score. So how tired are the healthcare workers? And you can see since the pandemic, and this is no surprise to anyone, that our healthcare workforce, including our stewardship workforce, is exhausted. Their burnout scores are either somewhat higher or much higher post-pandemic. So that is the backdrop of what happened to antibiotic use, what happened to stewardship programs during the pandemic. But there is some encouraging news here. In the United States, we have been assessing the implementation of stewardship programs in our US hospitals, asking them how many of them have programs that meet all 7 of our CDC core elements for hospital stewardship programs. This is a series of 7 components that we put forward as the elements of a robust hospital stewardship program. And we asked the hospitals, how many of these 7 have you implemented? And you can see here, we've continued to make steady progress in implementing these programs in hospitals around the United States. We've gone from about 41% of US hospitals having stewardship programs with all 7 of these elements to 95% in 2021. So even during the pandemic, we saw that more hospitals than in past years were able to implement stewardship programs that met all of the CDC core elements. So we've seen growth, and we've now built a tremendously strong infrastructure for antibiotic stewardship in hospitals in the United States. Well, now that most hospitals, almost all hospitals, have an antibiotic stewardship program in the United States, for us, the next question becomes, how can we take those stewardship programs from one level to the next level? We know that not every strategy for implementation for antibiotic stewardship is equally effective. We know from data that some practices are especially effective, and we know from experience that some practices are simply better than others because they're easier to implement, and any practice that you can implement more easily is preferred to something that's very, very hard to implement. As you heard from the other speakers, approaches and strategies that clinicians will not accept and that you cannot implement in the real world are not effective strategies. Well, what we did in 2019 when we revised our core elements for antibiotic stewardship in hospitals, we tried to identify some of what we called the priority approaches, priority implementation strategies. And we think it's now time to start trying to move people in that direction even more aggressively, because so many of our hospitals now have that stewardship infrastructure. What can we do to elevate our stewardship practices? We have identified in 6 of the 7 of the core elements, we have identified priorities for implementation. And we are now focused in the United States on encouraging our stewardship programs in our hospitals to focus their implementation efforts on these, these particular strategies and items. We know, however, that just having a stewardship program, just implementing a strategy, or having priority strategies is not going to miraculously fix antibiotic use. As Dr. Livermore has taught us and shown us, this is slow work that has to happen. There's a lot of building and understanding that we have to embark on. However, we think that having these priority implementation approaches are an important step along this very long journey that we are taking in antibiotic stewardship. The other aspect that I think we have to focus on is antibiotic use and measuring antibiotic use. Again, I think you heard this certainly from Dr. Livermore's comments, from Dr. Singh's comments. We have to measure the impact of what we are doing. And for antibiotic stewardship, part of that measurement of impact has to be the measurement of antibiotic use. In the United States, we do have a system that allows hospitals to submit data to us on inpatient hospital antibiotic use. We have seen tremendous growth of this reporting system. More than 2,400 hospitals in the United States have reported this data to CDC. And I will note that this reporting is completely voluntary. There is no requirement for hospitals to do this. So the only reason for a hospital to do this is because they see value in reporting this information to CDC. And more importantly, what this system does is it creates benchmarks, risk-adjusted benchmarks for antibiotic use. And the hospitals are finding that this type of ability to compare their antibiotic use against a benchmark has been incredibly powerful. Just as it's been so powerful, risk-adjusted benchmarking is so powerful and has been so powerful in infection control, we think it can also be brought to bear in antibiotic stewardship. For a long time in the United States, we have had debates and discussions about whether or not hospitals should be required to report their antibiotic use data to CDC. Mandatory reporting, a mandate for hospitals to report that data, would finally provide us the true national picture of hospital antibiotic use. It would give us all of the data rather than just a portion of it. And it could really help us see the uptake of new antibiotics to understand where they are being used and how much they're being used. We also think that there are some powerful applications of pairing antibiotic use data with antibiotic resistance data. And we think that this is both, to use the terminology from WHO, which I think is very good, both an access and an excess issue. For example, what if you have a new agent? What if we come up with a new agent to treat a highly resistant bacteria, and it's a very effective agent, and it would save people's lives if they were infected with that pathogen? But what if we see that the use of that agent is extremely low in a hospital that has a lot of that resistant bacteria? To us, that's an access issue, right? We would want to understand, we would want to know from that hospital, why do you use so little of this drug? Are you perhaps not aware of the applications of this new drug? This is a patient safety issue, as you just heard from the last speaker. Making sure that people have the appropriate therapy is a patient safety issue. On the other side, what about excess? And this could be important for excess as well, right? What if you have that new agent, but it's being used a lot in a hospital that has very, very little of that particular type of resistance? Again, that would be a marker of potential excess, and we would want to talk to that hospital to find out why they use so much of that particular drug. In the United States, we have finally settled on whether or not this data should be reported. We are now going to mandate this type of reporting, and I think this will make us a leader in this space, one of the first places where we will mandate electronic reporting of hospital antibiotic use data and resistance data electronically to the CDC. That will begin in 2024. And so we will have continued growth of this data. And I think we have some exciting times to come with understanding how we can use this data to really inform and drive our efforts to improve antibiotic use. I'm going to close by talking a little bit about some of the practical applications of stewardship and where I think we need to be focusing our antibiotic stewardship efforts right now today. Well, we know that in hospitals, and this is true in the United States, and it's true if you look at global surveys as well, there are a small number of common infections that are the drivers of the overwhelming majority of antibiotic use. And these three infections, respiratory tract infections, urinary tract infections, and skin and soft tissue infections, come up as the top three or near the top three in nearly every one of these global surveys. In the United States, these three infections alone account for more than 70% of antibiotic use. And we know that there are important opportunities to improve our treatment of each of these infections. It's not just in hospitals. Respiratory infections, as many of you probably know, are major drivers of antibiotic use in outpatient settings as well, and in nursing homes or long-term care facilities. So this is a very important target for us. And we think there are two key places where we can improve our management of these respiratory tract infections. First, the diagnostic side. We know that many patients who get labeled with a diagnosis of pneumonia when they first present to the hospital actually don't have pneumonia, right? They have, or don't have bacterial pneumonia, I should say. Maybe they have COVID. Maybe they have another type of viral pneumonia, or maybe they have heart failure or some other reason to have chest X-ray infiltrates and a cough. So we should focus and continue to improve our diagnostic efforts. I do hope that this new normal that COVID has brought in, where clinicians are thinking more about viral pneumonias, they are testing for COVID, and in some places expanding that testing to both flu and COVID. I hope clinicians now are beginning to think, could this be a viral pneumonia? And maybe that new use of viral diagnostics and the acceptance of the fact that viral pneumonias are a real entity and can mimic bacterial pneumonias but do not need antibiotics. I am hoping that that will help us usher in a new era of diagnostic improvement for respiratory tract infections. The other place where we can improve our management of respiratory tract infections is with the duration of that therapy. We know that in the United States, at least, that pneumonia is treated for far too long. Most of the guidelines will tell you that pneumonia should be treated for 5 days in the overwhelming majority of cases, maybe up to 7 days in a smaller number of cases. But here in the United States, if you look at all hospitalizations for pneumonia, in about 70% of the cases, treatment is longer than 7 days. It is unnecessarily long. And we know that every day that a patient is getting an antibiotic that they don't need, they are exposed to potential harms from that antibiotic, and they are getting no benefit from that treatment. It is a safety issue. We also know that here in the United States, and I suspect this is true around the world, that most of that excessive therapy does not come when the patient is in the hospital, but it happens when they are being discharged. And so it is a good reminder to us, and this is an excellent study that demonstrates that point. 93% of the excess duration came after the patient left the hospital. So it calls on us to review the therapy at the time of the patient's discharge and make sure that we are prescribing the outpatient therapy for the proper duration rather than an excessive duration. Urinary tract infections, we heard about this as well from Dr. Singh. A very, very common reason that antibiotics are prescribed in hospitals, but many cases, it is not an infection that is being treated. It is purely asymptomatic bacteriuria. The patient has bacteria in their urine, yes, but they do not have a urinary tract infection. And there are some very, very good studies, and this relates to that theme of what we call kind of diagnostic stewardship, right? As a way to improve antibiotic use, it's improving the way we use our diagnostics for infections. In this case, they really focused on improving when urine cultures were sent. And they developed a very short checklist to say, if you're thinking about sending a urine culture, your patient should have at least one of these criteria, fever, for example. And if your patient has none of these criteria, they probably don't have a urinary tract infection. Don't even send the urine culture, because we know once the culture is sent and the results come back, the providers are going to be very, very tempted to treat the results of that culture, even if the patient doesn't have an infection. So why not start with the diagnostic? Don't even send the culture if there's a low or no clinical suspicion of a urinary tract infection. A very effective approach, and I would add, it is a good approach for reducing wasted resources, right? If your labs do not have to process these cultures, it saves time and it saves money. And you also heard from Dr. Singh, so important that we eliminate the waste of resources so that we can maximize our resources in healthcare. And finally, skin and soft tissue infection. These are oftentimes the wrong agents are used. Providers oftentimes are using excessively broad spectrum therapies with a lot of gram-negative activity to treat infections that are overwhelmingly caused by gram-positive organism. And we know that duration of therapy is often, again, excessive for skin and soft tissue infections. So those three infections, lots of good evidence that we can improve the way we manage those infections. And so I would argue that those are the places that we should be really focusing our stewardship efforts. I will close by saying a little bit about our efforts to engage the public in this, because we know that engaging our patients and their caregivers is so important when it comes to our efforts to improve antibiotic use. This has to be a partnership between providers and patients. We have to reduce the antibiotic seeking behavior in the public. And that's why we focus on antibiotics with the Antibiotics Awareness Week, a global week of awareness. And this year it will be at the end of November, November 18th through the 24th. These are some of CDC's efforts during that week. And the WHO has a host of wonderful resources for Antibiotic Awareness Week. And we hope that you can use those resources and take this opportunity in November to educate both providers and patients about the importance of improving antibiotic use. So with that, I am going to stop my presentation and turn things back over to Keith and Dr. Sharma for some discussion. Thank you so much.
Well, thank you. That was an excellent presentation. And I really appreciate you sharing some of the preliminary data coming out of NHSN on the antibiotic use. And, you know, I was wondering, you know, when you made that comment about the CMS mandate, which will, you know, require institutions to report that data. Does that include both antibiotic use and antibiotic resistance data?
Yeah, Keith, that's a great question. And it does, right? Because we know that those two pieces of information are so complementary. And I think you've heard that from the other speakers as well. Dr. Singh touched on that in his talk. Use helps us understand resistance, and resistance helps us in understand and improve use. So yes, both of those data elements will be reported to the CDC.
Well, I think for those on this symposium that maybe are not as familiar with the logistics of that, it does require electronic HL7 interfaces, you know, from the electronic medical record. There's no manual reporting of this data in those modules. So that's a giant step forward, I think.
Yeah, it is. And I think this is the type of transformation. And we touched on a little bit in the last presentation, you know, the desire and the need for transformations in this space of patient safety, antibiotic stewardship. Yes, we do think this is a transformative step forward. This is data that is incredibly burdensome to try and collect and report manually. So this is a pilot step for us. You know, we will be gaining experience with how we look at this data, and hopefully our experience here can help inform others who are interested in also using their antibiotic use and resistance data and working on those comparisons and correlations.
Well, I want to give Dr. Sharma some opportunity here to ask questions, so please do.
Thank you, Mr. Keith, and thank you, Dr. Srinivasan, for an excellent presentation on antimicrobial stewardship in USA, especially in the context of the COVID pandemic, especially your point on your focus on diagnostic stewardship and engaging the public, I think, are extremely important, you know, especially from the public perspective. How do you ensure you sort of make AMR everybody's business by making it a personal social responsibility of everyone, not just the technical people involved in AMR, but also the public? So I have a question for you. You sort of focused your talk primarily on antimicrobial stewardship. Of course, you did sort of talk about antimicrobial consumption at the national level, but primary focus was on the healthcare institutions. But, you know, with AMR, One Health being an important thing, how do you ensure antimicrobial stewardship at the health system level or at the national or the government level? What do you think are the critical factors for pushing AMR containment at the health systems level and the national and the government level?
Yeah, that's a great question, Dr. Sharma. And it's, you know, I think what we have focused on at CDC, you know, we know that at the national level and the government level, we don't prescribe the antibiotics. So we do our role as working to create the conditions which would favor the optimal prescription of antibiotics. And I think that applies both on the human and the animal side. And my experience, of course, is exclusively on the human side. So what we have focused on is creating things like our core elements, right? So trying to point health systems and hospitals to how do you have a good stewardship programs? What are the policies? What are the practices? We also know that, you know, just creating those types of documents is not enough. You also have to work on incentives and requirements, right? You have to really move people in the direction, not of just reading the guidance, but of implementing the guidance. And so here in the US, we've worked with our regulatory agencies, our healthcare facility accreditation organizations like the Joint Commission, to encourage them to make this part of their requirements. You know, the Joint Commission has a standard, a requirement now to have an antibiotic stewardship program. So we have now some policies and requirements in place that can make that happen. The other place where we also need, and I don't think we have been as successful here, is we need resources for this. We need for the healthcare facilities to have the resources at their disposal, the human resources, the information technology resources in order to do this. That is, I think, still an area where we need to do much more. But that, I think, is another really critical role that the government and organizations could play. And would turn it back over to you to see if you have additional thoughts, because I know you think about this a lot from your position at WHO.
Thank you. I think you've really focused on the resources, and critically, I think from the health system's perspective, it's ensuring that the policymakers allocate resources. And I think we, as AMR champions, as technical people, we tend to focus a lot on the technical issues. And I think it's very important to get the politicians, the policymakers at the national level, to ensure that they allocate the requisite resources in all the sectors, not just in human health, but the other sectors as well. And that is something which really is a challenge in a lot of countries. And I think maybe you'll have some thoughts about how USA did it to ensure that you have the requisite resources from your policymakers. So what do you think were the key issues that got the policymakers or the politicians engaged for AMR containment in the US?
I think it's work like what we're doing here, right? It's continuing. It's the hard work of raising the awareness and the profile of this issue, making it clear that this is an impact, that this is an issue that impacts everyone's health. And I think politicians understand there's nothing more important than health, and we have to protect health.
Yeah, I was thinking, Arjun, that President Obama actually established a committee that would focus on this, and that got very high level, congressional attention, which is continuing. And I think that having that leadership by senior officials in government can truly have an impact on human health. And I think that, again, it's not a matter of us wanting to be elitist about this. I think it's really important that we share this information, and the way it, was crafted, if you will, for the whole world to take advantage of this. And I think, one of the questions I wanted to ask you is, I think it's really wonderful how you distilled the 7 core elements. I love the graphics, but many around the world are just beginning to start an antimicrobial stewardship program. And I was wondering if you had to prioritize one to start with, which would it be?
I think it's a challenge because we view all of these as being kind of so interdependent.
Right.
You ultimately, the goal of stewardship is to have actions to improve use, but those actions probably won't be implemented unless you have some sort of a commitment from leadership, unless you have some of the infrastructure in place in order to make those happen. So what we have told people is, you should look and see in most places, as you start your stewardship program, it's to look and see, how do you bring each of these things online? How do you get the support? I would say that if you're just starting your stewardship program, the first place to start is working with the leadership of your facility. You have to have the commitment of the leadership of your facility for stewardship, because that will help you set you up to get everything else that you need. So I would say that is the place to start.
Totally agree. Totally agree. Thank you. Well, I've been scanning the, chat to see if there was any additional questions. I have not seen any, other than a lot of thank yous for an outstanding presentation. So we definitely pass those along. But if there are not any additional questions at this time, are we running on time, ahead of schedule, or over schedule, Dr. Mayer?
Like you, we've enjoyed our journey over the extended sessions we've had. Dr. Arjun Srinivasan being the last speaker is never easy, and you've kept us riveted with your absolutely fantastic talk, with excellent data and excellent understanding and explanation of that data. You carried us with you, and we've appreciated the kind of work CDC is doing and the kind of interventions that still need to be done, and how engagement continues to be one of the priorities. Engagement, advocacy, of course, is important. Funds are important. Commitment from leadership is important. But then the engagement of the person who's going to implement it is as important. And what you've told us is that the empathy at how, when one discharges the duties, one needs to have empathy and then bring out the changes, which require, of course, behavioral changes. And we can work on that. And the commitment, I would say, ownership of all these resources we have, of collective ownership, so that the guidance comes from the top, but the ownership is taken by not just the healthcare practitioners, but by the citizens at large. And that I feel is where we will bring about a real and lasting change. Thank you, Dr. Arjun Srinivasan, for that absolutely fantastic talk. And I now have the pleasure, and I hope my slide works, is to invite our dynamic head of department, microbiology and immunology, and senior consultant, Dr. Zakaria Al-Muharrami, for his final words and, of course, vote of thanks. Dr. Zakaria, please.
Thank you very much, Dr. Mihar, and thanks to everyone who made it till the end of this highly scientific event. As you are all aware, in November 2021, the WHO has declared that AMR is one of the top 10 global public health threats facing humanity. And as frontliners in the face of this threat, we are aware, or at least partly aware, of how ugly the face of AMR is. But other colleagues, either physicians or nurses, hospital administrators, and specifically policymakers, might not be as aware as you are. So one of our multiple roles as specialists in this field is to help them by creating awareness. What our experts try to do today is to simplify the methods by which we can carry the message to other people. I fully agree with Dr. Livermore with the using of simple antibiotics like nitrofurantoin. However, I can also understand that physicians would need to be reassured that if they use it or similar antibiotics, that it will work. So that's why we need to provide them with antibiograms and with simple tests of susceptibility. I liked really the state of Kerala experience in AMR containment, especially involving private sector and agriculture field, because especially the agriculture where tons of antibiotics are being consumed is being overlooked. Dr. Pawan Kapoor talk about patient safety is very comprehensive, especially when he emphasized the importance of introducing this topic in training and education of medical students. I think all medical schools should do that. I like Dr. Arjun Srinivasan, I hope I'm pronouncing it correctly, when he talked about rationalization of stewardship strategies, because like anything else, these toolkits cannot be universally used everywhere. Each institute has its own resource constraints and has own circumstances. So we have to realize that. At the end of this talk, I would like to thank all the people who made this event possible. And in particular, I would like to thank the Dean and our Director General. I would like to thank also Dr. Raman Sandrana, the Secretary Hospital Infection Society in India, and ASM. I would like also to thank Aston Diagnostics in Oman for their support, financial support to this event. I would like to thank all speakers, moderators, and other resource persons. I would like to specifically thank the members of my Department of Microbiology and Immunology, especially Dr. Mihar Razwi, who is the dynamo, the working force behind all the success of today's event. I wish you all a very great day, or what is left of it. So thank you and have a nice weekend. And Assalamu alaikum.
Thank you. Thank you so much, Dr. Zakaria, for that excellent roundup. Ladies and gentlemen, we have been in the company of giants, and we have been elevated from where we were 2.5 or 3 hours ago to where we are now. Let us continue on the road of improvement of quality healthcare and improvement of, say, mankind. Thank you so much. Thank you so much, all our eminent speakers. Thank you so much, our eminent moderators. Thank you so much. As Dr. Zakaria said, he's already thanked everyone. Nothing needs to be left. He said everything. Thank you so much, everyone.
Thanks from Hospital Infection Society, India House. So the whole family is very grateful. Thank you.
Thank you, Mayor. Thank you, everyone. God bless you all.
Thank you.
Thank you, everybody. Thank you, Dr. Meher. It's a wonderful symposium. Keep it up.
Thank you, Meher. It was wonderful. It was really a good evening listening to such great lectures and such great communication. Remember you and feel proud about you.
Thank you. Thank you.
Thank you.
Three cheers for you, Mayor.
Dr. Meher, it was a wonderful effort and wonderful execution from your side.
The credit goes to everyone, and I hope we continue working together and create good outcomes and good changes.
Thank you, Dr. Meher.
Thank you, Dr. Adila. I'm really happy that so many of our Dash to Protect Antibiotics people were here, and with all the encouragement we've got from all these great people, I hope we come up with some renewed and get down some good work.
At least it gives a reassurance, Mayor. I think that's something which is that people are working towards right path and then moving towards attaining something beneficial for society. So I think that's a great reassurance coming from all these stalwarts.
Yes, yes.
Good one. Thank you. Keep up the right track.
Yes, we need you. We need like you to galvanize us to work towards, what should I say, optimal patient care or quality assurance. What do we say? But we need to just keep going on. Thank you, Dr. Renu. Seeing you.
Lovely. Excellent, Mayor. Well done. Well done.
Thank you so much, sir, for your support. Couldn't have done it without you. Absolutely, the guidance is phenomenal. And we'll regroup. Our group will regroup, I think, a week or so, and then we get down to working together again. Thank you so much. Have a good day. Good night. And
have a wonderful time, you and team. Yes. Lovely.
I think we'll leave for the audience to just wait for the audience to leave. I'm so happy that all our PIs from so many different countries could join and could contribute. And their interest and their motivation is really phenomenal. We've been working.
I think you probably will have to expand the centers now. People are getting interested, so there's a time when you can think of, because the iron is still hot. You can work upon getting more centers.